Just and working in Batra Hospital mainly, but he is traveling all over India to help the patients through various hospitals. Dr. Yadav, please.
Next. Okay. So, thank you, sir. Thank you for the opportunity. So, as you know, there are background guideline recommendation and some transcatheter mitral valve repair new and investigational.
Let me give the little background about this actually. This new technique, mitral regurgitation. Normally it happens, we have been knowing about rheumatic heart disease, but in secondary MR, in heart failures, wherever we have this causes a lot of problem to the patient, especially dyspnea on exertion, sometimes rest dyspnea, left ventricle, left atrium gets dilated, atrial fibrillation. So it's actually a major problem in the patients who have a dilated heart. So heart failure patients, in these patients we have a normally mitral valve replacement is done, but mitral valve replacement is normally contraindicated when they have a severe LV dysfunction or rather very high risk. So we have devised, the interventional cardiologists have devised a technology where you can repair the valve without opening the chest, again percutaneous technique. So Dr. R.D. Yadav is going to highlight further about this.
So as you know, there are two types of mitral regurgitation. One is called primary, that is degenerative mitral regurgitation. And the second one is called secondary mitral regurgitation, that is also called functional mitral regurgitation because of LV systolic dysfunction or because of LV enlargement or because of LV papillary muscle dysfunction or rupture or atrial enlargement. All causes, these are secondary mitral regurgitation. And mitral valve repair by using Mitra clip or Pascal device, these two devices is for clipping into the mitral valve, leading to two outlets like double outlet mitral valve having two outlets, which decreases the mitral regurgitation without causing mitral stenosis. So mitral regurgitation is the most common valvular disorder in the US, and it's underdiagnosed, even not underdiagnosed but undertreated also. Even after diagnosis, treatment is mainly medical therapy and hardly patient referred for the Mitra clip procedure or surgical procedure. So severe mitral regurgitation, as you know, is associated with increased mortality and increased rate of heart failure hospitalization, which leads to decreased quality of life. And etiology of mitral regurgitation is varied because of the complex anatomy of the mitral valve, thereby complicating the mitral valve regurgitation treatment. As you know, mitral valve anatomy is complex mitral valve anatomy, and it includes annulus, mitral annulus, leaflet, papillary muscle, and chordae tendineae. So all these four structures made together forms the mitral valve complex. And mitral valve complex, anything goes wrong, either annulus get dilated, papillary muscle get ruptured or dysfunction, chordae tendineae gets ruptured, all cause mitral regurgitation. And they can be all treated very well. And as you know, mitral regurgitation is not a single disease entity. Mitral regurgitation is having, because of left atrial dysfunction, causes dilated annulus, or because of LV dysfunction, causes dilated LV. So that is called LV ventricular mitral regurgitation or LV mitral regurgitation. And when LA is dilated, causing mitral regurgitation, is called left atrial mitral regurgitation. And these dilatation leads to annular enlargement, papillary muscle displacement, causing inability to cap the leaflet and leading to mitral regurgitation. And this papillary muscle displacement also causes leaflet tethering and tenting, and which leads to mitral regurgitation. And in degenerative mitral regurgitation, that is called primary mitral regurgitation, DMR also that is called, it's like advanced Barlow's disease, that is mitral valve prolapse or tip prolapse or pleural mitral leaflet, fibroelastic deficiency is in some of them leading to mitral regurgitation. And this leads to leaflet deformities or lesions, ruptured elongated chordae, and papillary muscle rupture. All this is called primary or degenerative mitral regurgitation. And here this view of 3D view is very, very important view for mitral clip, where you aorta is above, and here lateral is on this side, and medial is on right side, and posterior here on the back side, and aorta is anterior, and clip has to be between the 12 o'clock and the 6 o'clock, so that it makes the mitral valve orifice 2 in number. So how the mitral clip leads to problem? Most important nowadays is the functional, most common is functional mitral regurgitation due to heart failure. And out of this you see, the more the severity of functional mitral regurgitation, more the mortality, as well as the heart failure hospitalization. So transcatheter device, so surgical procedure which used to do is the leaflet resection, alveoli repair. Alveoli repair is the same what we do by clipping. So alveoli repair was used to be done by surgery by stitching the two leaflet in the middle or prolapsing part and make the two orifice of the mitral valve. Same can be done by catheter-based treatment. And another one is the annuloplasty. So people do both annuloplasty and alveoli. That is a better result. And caudal repair, if there is a caudal rupture, they do the caudal resuturing and caudal repair. So all these are the type of operation. These are the repair operation. But another operation is the mitral valve replacement, where you put the either bioprosthetic valve or metallic valve. So this we do by alveoli is done by mitral clip, and so primary MR, as I told you. And if you see the guideline says if there is a primary mitral regurgitation, even if the patient is asymptomatic, severe mitral regurgitation, even asymptomatic, if the ejection fraction is less than 0.60, means 60%, less than 60%, and LV in systolic volume more than diameter more than 4 centimeter, they require surgical repair or replacement, depending on the age of the patient. Along with that, even asymptomatic severe MR requires treatment if ejection fraction is less than 60% and LV in systolic dimension is more than 4 centimeter, diameter is more than 4 centimeter. Along with that, if that is not there, if other one risk factor is there, like one or more, like new onset atrial fibrillation or resting PA systolic pressure more than 50 millimeter of mercury, progressive increase in the LV in systolic dimension towards 4 centimeter on transthoracic echo, progressive decrease in LV ejection fraction below 60 on serial transthoracic echo. If that is happening, one of the criteria, then also if that criteria is there, they need surgical mitral valve repair. So even asymptomatic severe mitral regurgitation requires treatment, and most primary one most likely by the surgery. But if these criteria are not there, then patient can be followed up with medical therapy. If patient is symptomatic, severe mitral regurgitation, they need surgical repair. And if, say, prohibitive risk, you cannot do surgical repair because of the other risk factor, other comorbidities, you can well manage with the mitral clip, that is the mitral clip, or by the Pascal device, that is mitral valve clipping. And this is the mitral clip, which has several, here if you see the mitral clip has a, this is clip, and this is the gripper, which grips the leaflet between the clip and gripper grips the leaflet between the clip and gripper, and then close it. Then it close it. So this is the technique, and if you close it, it will having two orifices of the mitral valve. It will look like this. And these are the handles, and these handles are very important to learn when you are doing the procedure. It's a not very difficult procedure. Only thing is the problem is the cost of the procedure, because the device is by only one company, so it's quite costly, around 25 lakhs for this device, and implantation charges and all around another 5 lakhs. So that cost around 30 lakhs or 32 lakhs. So this is the issue. Doing the procedure is not that difficult. So I'm going to tell you the latest trial, and latest trial is the COAP trial, which has got 5-year follow-up. There are some registry, I'm not going to discuss about that. And among this COAP trial in secondary mitral regurgitation, severe, moderate to severe mitral regurgitation with LV systolic dysfunction and heart failure. And this is 5-year follow-up, presented just a few months back. And what it showed in 5-year follow-up COAP trial is MitraClip plus guideline-directed medical therapy in 305 patients. And another group was taken is the randomized with the guideline-directed medical therapy of severe mitral regurgitation, LV systolic dysfunction. And the effectiveness of the procedure was well done. If you see what it did, hospitalization of the heart failure patient was significantly reduced. First hospitalization of heart failure was also significantly reduced. Death from any cause was significantly reduced. And if you see the degree of benefit, death from any cause or first hospitalization for heart failure were markedly reduced in this person because of the LV systolic dysfunction with mitral regurgitation. It's a double jeopardy. So by reducing the mitral regurgitation, you reduce the your LAV pressure, that is pulmonary capillary V pressure, wedge pressure, and you reduce the pulmonary arterial hypertension, and patient feels better. So this is very, very important therapy, and it should be done, it should be acquired. The only problem is the cost, and probably the China device that is called Reliant device, which is cheaper than MitraClip, maybe 2.5 lakhs or so. They are costing, but they have not yet introduced in India. Then the cost of mitral regurgitation management will be easier. And if you see the benefit of heart failure hospitalization starts from beginning of the month, and its curve separates early, and the mortality benefits comes in 12 months. So the heart failure hospitalization is immediately improved. Patient doesn't go into the hospital recurrently and heart failure patient because of MR and pulmonary edema. And mortality benefit comes in 1 year time, but it's a durable 5-year time, significant decrease in mortality. And this benefit is consistent without any increase in MR on due course. So COAP trial has clearly shown is more beneficial, and if you see the degree of benefit is immense. So much so that if you will put in 6 patients, if you will put in 3 patients, 1 patient will get benefited. So is one of the therapy where the mortality benefit is great. So 5-year follow-up, the conclusion of this study is that transcatheter edge-to-edge repair of the mitral valve was safe and led to a lower rate of hospitalization for heart failure and lower all-cause mortality through 5-year follow-up than medical therapy alone. New device, that is G4 device, generation 4 device, has more bigger clipping, so more bigger clip, so it causes better clipping. By single clip is enough in most of the cases, and it helps as if annuloplasty is also done and found to be superior. So new G4 device has already introduced in India, and it's doing well. Thank you, sir.
Just a minute. I think Dr. R.D. Yadav, please stay back, because we have a video. Before that, let us have a video about mitral regurgitation, mitral clip repair, and then we will have questions and some discussion. मैं देख रहा हूँ, उसको छोड़ दो, मैं कर रहा हूँ. This is a technical video. I have taken a permission to talk about this, and then this will be moderated by Dr. R.D. Yadav himself, because he is master in this. Can we have the sound?
In this video, we'll present the MitraClip implant technique
This
for
implant
transcatheter
technique, sir.
mitral valve repair from the Valley Health System in Virginia. We present the case of an 84-year-old frail lady with severe symptomatic organic mitral regurgitation who presents with class 3 symptoms. She also has multiple comorbidities including frailty, prior stroke, diabetes, and advanced kidney and lung disease with pulmonary hypertension. She has a predicted risk of mortality of approximately 15% by STS and has technical considerations including moderate annular dilatation and mitral annular calcification. Due to these reasons, we thought that this patient would have a very good option in a MitraClip transcatheter mitral valve repair as an alternative to surgery. The MitraClip system components are important to understand by the proceduralist. The MitraClip device itself consists of the clip arms as well as the gripper. However, the delivery system is somewhat sophisticated and requires thorough awareness of all the available components. The clip delivery system has two separate components. The first is a steerable guide, sleeve, and delivery catheter, which controls the delivery sheath. A second component delivers the clip, which includes a delivery catheter handle and system, which control the movement of the clip that allow appropriate grasping of the leaflets. The patient is positioned supine in the hybrid operating room and general anesthesia is induced with endotracheal intubation. Invasive arterial line monitoring is achieved via the radial artery and large bore venous access was inserted into the right internal jugular vein. Swan-Ganz catheter is not typically used. Patient is then prepped and draped in the usual fashion with exposure of both groins, and preoperative prophylaxis antibiotics are administered per usual protocol. The right femoral vein is obtained for large bore access, and systemic heparinization is administered for an ACT of 250 to 300. Transesophageal echocardiography is mandatory for guidance, and the use of 2D and 3D live transesophageal echo using X-plane and 3D en face views is essential for successful deployment. Fluoroscopy is also mandatory for guidance and observation of catheter MitraClip deployment. Unlike transcatheter aortic valve replacement or surgical mitral valve repair, the MitraClip, along with other TMVR procedures, require truly a team approach between the echocardiographic guidance and the proceduralist to achieve a successful result. Specifically, the valve team should have a uniform terminology to discuss the navigation of the MitraClip hardware based on navigational echo with 2D and 3D TEE with X-plane and 3D en face views being the most common. Other common echo views include the bicaval view for transeptal puncture, the intercommissural 2-chamber view, 4-chamber and 5-chamber views, as well as the transgastric short axis views. Similarly, fluoroscopy is important for positioning of the steerable guide into the left atrium, device delivery of the catheter for straddling, as well as position of the clip into the left atrium. Axial alignment and opening of the clip arms also require fluoroscopic guidance, as well as identifying gripper position, as well as clip release and device withdrawal are all done under fluoroscopic guidance. The MitraClip implant technique is really divided into 5 distinct steps. The first is baseline imaging with comment on leaflet anatomy, segment and scallop prolapse, leaflet tethering, calcification and perforations, with also special attention being paid to transcatheter valve gradient, annular size, and any potential septal concerns that would render transeptal puncture a difficult process. Second, the transeptal puncture is performed with special considerations to location confirmation and safety, followed by steering and positioning of the MitraClip device into the straddle position, clip axial orientation above the mitral valve annulus. This is then followed by leaflet grasping, insertion assessment, and deployment with significant pre-deployment imaging assessment for tissue bridge, gradient, and regurgitation, followed by clip release and post-release evaluation. In the end, an assessment is made for the need for any potential further clip placements for a second or third clip, as well as system removal for conclusion of the procedure. Deployment of the Mitra clip requires significant knowledge of the Mitra clip steerable and catheter guidance, and this takes quite a bit of practice and a steep learning curve. The guide handle controls the anterior and posterior movement, whereas the sleeve handle controls the medial and lateral as well as the anterior and posterior movement. The clip delivery handle controls clip position, grasping, and deployment, whereas the stabilizer movement controls the medial and lateral movement of the clip and steerable guide. Baseline imaging is performed in this patient, and we identify a prolapsed posterior leaflet at the P2 scallop with well-functioning ventricular function, and further delineation of 3D TEE confirms the finding of posterior prolapse with a flail chordae in the middle of P2. Further 2D echo confirmation reveals an anteriorly directed jet that further confirms the P2 isolated scallop prolapse. At this point, transeptal puncture is the first step of the procedure through the right femoral venous puncture and insertion of a large bore sheath. This can be performed through the Baylis radiofrequency transeptal needle or the Brackenborough needle and the Mullins sheath approach. However, approach preferred by the operator, the transeptal puncture is usually performed through a pullback technique with low and steady retraction from the superior vena cava into the mid-fossa ovalis under TEE guidance using a bicaval or the 4 or 5 chamber views with X-plane along with radiofluoroscopic confirmation of the transcatheter needle location. Once identification of the mid-fossa ovalis is observed, with tenting, the puncture is then desired at the superior and posterior aspect of the fossa to allow for optimal insertion of the guide catheter for easy maneuverability into the left atrium and delivery of the mitral clip. The puncture is also needed to be positioned 4 or 5 centimeters above the mitral valve annulus in organic disease and around 3.5 centimeters in patients with functional disease, since the line of coaptation is usually below the annular plane. Many sites often prefer to insert a pigtail catheter into the aortic root as an extra anatomic landmark to further delineate aortic anatomy through the transeptal puncture. Once the puncture is made with a small needle, confirmation of left atrial pressure is important to confirm anatomic location before further dilatation is carried out. Once confirmed, a small 018 wire is inserted into the left atrium, then intraatrial hole is dilated and Mullins sheath is advanced into the left atrium. Heparin is administered with an ACT goal of 250, and a pre-curved 260 centimeter stiff 035 wire is then inserted into the left atrium. A left atrial angiogram can be performed at this point to further confirm the size and the anatomy of the left atrium. And next, we remove the large bore sheath and insert the steerable guide catheter into cone-shaped dilator under fluoroscopic guidance with 2D and 3D TE monitoring. The dilator and wire are then removed, and the guide catheter is placed at 3 centimeters into the left atrium across the septum. Steering and positioning of the MitraClip device, requiring position of the metal stabilizer over the right leg and preparation of the clip on the back table with removal of any air within the system. And the clip delivery system is then advanced carefully into the left atrium until the system tip ring marker is centered between the sleeve alignment markers with a fluoroscopic confirmation, which is often referred to as straddling, occurs. Once this is achieved, the delivery guide and the delivery system are then maneuvered within the left atrium carefully using TE guidance to clear the left atrial wall, the Coumadin ridge, and position the MitraClip centrally over the valve. This is achieved using minor, repetitive adjustments using torque and knob adjustments. The TE observation in 3D short axis on fast view with the clip is then unlocked, the grippers are raised, and the clip arms are opened to 180 degrees with fluoroscopic confirmation. TE is then used to confirm perpendicularity at 12 and 6 o'clock positions with respect to A2 and P2. The clip is then advanced through the mitral valve annulus in a location that splits the mitral valve regurgitation jet under TE guidance and intercommissural 2D view with X-plane. Appropriate orientation of the clip with alignment perpendicular to the line of coaptation and freely moving leaflets above the clip arms is essential to effective grasping of the mitral valve leaflets. once in good position to maximize likelihood of firm grasp of both leaflets, under 2D TEE LVOT view, the leaflets are then grasped with gripper arms and then clip arms are closed fully. Insertion assessment is assessed thoroughly with TEE. The clip is then released through a series of maneuvers involving the delivery catheter system fastener, release pin. The lock sequence clips are then reopened in the left ventricle, then subsequent leaflet grasp and mitral valve assessment is performed in the same manner. Once procedure is concluded, the delivery catheter system and steerable guide are withdrawn. The MitraClip transcatheter mitral repair technique is a safe and effective procedural alternative for the reduction of severe organic mitral regurgitation in well-selected non-surgical patients. Some recent evidence from the COAP trial has also shown promise of the MitraClip device, as well as potentially some other transcatheter mitral technology in severe functional mitral regurgitation patients. Some recent rapid improvements in the MitraClip device, including the NTR and XTR devices, as well as advancements in TEM, and bodes well for patients of both organic and potentially
RD, with your permission, I think there is a Saibal Kar. I spoke to him, and he has 10 comments about this MitraClip before we go on for discussion, and then we go to the next. So I have to see that recording. Saibal Kar is an Indian from...
Once again, thank you for inviting me. It was difficult for me to come from
He's
Paris
a very important
here.
cardiologist.
Everyone's crying you were in Paris.
Okay.
Indian origin cardiologist based in US. He is also versatile cardiologist like Dr. Adi Yadav. We will talk about 10 points.
Does this go
and then we'll
forward?
take quickly 5 minutes.
Oh, I have questions, yes. Yes, I have 3 polling questions, right? They're simple, they're nothing.
MitraClip
this
is a
the
very
MitraClip.
important
I think
technology.
the Canadian ones
upcoming.
and the US one, I think, are similar, right? If so, the MitraClip has been approved for the treatment of high-risk functional MR, high-risk primary degenerative MR, for selected patients of both high-risk and functional MR, and of course, for all groups. And the answer is?
Actually, course
Okay.
he is talking about, yeah. Indications.
So I think most people got it right? This is a nice question, okay? This is an 82-year-old gentleman with non-ischemic cardiomyopathy here for 25%, severe functional MR arising from the central part of the valve, NYHA class 3, and the patient happens to be your uncle. So you have options. You can do a transcatheter mitral valve repair with a MitraClip, mitral annuloplasty with a Carolan device, surgical repair or replacement, or transcatheter mitral valve replacement, either transapical or transeptal, whatever you want.
Well, if you don't like your uncle, you might go with
Okay.
D, but.
So let's see what the answer is, okay? Okay. But this third question is more interesting because you don't have to answer it. What if the same scenario, but the patient happens to be your mother-in-law you don't like?
Exactly.
If the patient happens to be a mother-in-law. Very,
So thank you very much. Okay, so I remember I had the fortune or misfortune of treating Lee Benson's sister's husband, right? And I think he did well for some time. I remember he had an ejection fraction of 20%. 10 most important keys to success of MitraClip. I know there are a lot of pediatric cardiologists there. How many people are doing MitraClip or involved in a MitraClip program? So that's quite small, actually. You can use it in kids, in the tricuspid valve. So these are my conflicts. I get money from all companies, so I'm so conflicted that I'm actually very neutral. So when it comes to MitraClip, as you can see, this was based on the Alfieri stitch, which is a very simple operation of putting leaflets together and coapting the leaflets exactly where it leaks from. It was a very simple operation, and most surgeons, including Tyrone David, thought it was just a waste of time. And truly, actually, he wrote one of the best papers on the Alfieri stitch, showing that in anterior leaflet prolapse, it actually works very well. Alfieri, I remember I had the opportunity of meeting him in 2006 when I first spoke about MitraClip, and no one believed me, of course. And when I was in Europe, there were 6 people in the audience. 3 were from the company, and the other 3 were just speakers. So there was actually no one. And the person sitting near me was Alfieri. So I met him for the first time. I said, wow. And he said, look, he said, how many have you done? I said, I've done 10 cases. And he said, okay. He says, nobody believed my operation, but you will live my dream. And that came true. Now, exactly 10 years later,
Interruption. There is a car HR26CR8999. I think it's blocking somebody. Somebody's there? HR? Okay.
there are over 60,000 cases done worldwide. So the MitraClip basically catches the leaflets by between the ventricular arms and the atrial grippers, and then independently you bring the leaflets together. And the beauty of this procedure is that because there are no sutures through the leaflets, you can actually recapture, you can reposition, and if you don't like it, you can just come out. So it's reposition removable, and therefore it is useful in any patient, and it's therefore impeccably safe. This is NT is the new version of it. Can I show you that? I'm sorry. Let me go back to that. If you look at the grippers, you see when the grippers go down, they go down completely. You see this, look at these grippers. Can you see how the grippers go down? So they go right down, so they catch the leaflets in 180 degrees. And then you easily, well, the other one, it went just up, so the leaflets could slip out. So this one, it's easier to grasp the leaflets. That's the only difference. This is what it looks like. You can see this is a flail posterior leaflet, and you're gradually getting it, allowing the leaflets to drop. You drop the grippers, and then you close the clip under echo, and you get a double orifice valve, especially where it's flail, all of this under control. And I know Eric loves this procedure. He just hates it. So there's a couple of things about this vascular access. And I know Eric doesn't like about it because there's no arterial access in the groin, no application. It's a single venous stick, single perclose in the vein. Some cases a radial arterial line, some cases a right internal jugular vein. Our initial procedures used to take between 4 to 5 hours, sometimes 6 hours, right?
And now they take 4 to 5 hours, sometimes 6 hours.
But now they take probably less than an hour. But the beauty is that even in those days when it took 4 to 5 hours, it still was a safe procedure. Do you agree with that, Eric?
Yes, absolutely.
That's right. When it comes to, I'm going to talk about the success of the clip. What are the things that you should do? Just common things. I'm going to talk about case selection, vascular access, imaging. So I'll go through simple things since I don't have much of time. Case selection, what John said, high risk or sick but not futile. You just remember, MitraClip is not a part of the ACLS or BLS program. We get patients who are 10% EF on 3 drips on ECMO, and they say, can we have a MitraClip? I said, no, it's better to plan the coffin instead. So that's not good. Second is adequate mitral orifice. If your mitral valve area is less than 3.5, especially 4 with the cutoff, 3.5, then you should probably not try it, because if you do it, you're going to get mitral stenosis. Adequate leaflets to grasp. So I'm not going to go into details, but if you have a flail segment, that flail cannot be too large, and the leaflets could not be too wide. So if you have a flail width of greater than 15 millimeters, you probably will not be able to tackle it with 2 MitraClips. It will probably cause severe MR or severe MS. Avoid rheumatic heart disease. It's not effective in rheumatic valve disease, because what happens is there's commissural fusion, and the leaflets are retracted. And therefore, when you do a MitraClip, you actually cause severe stenosis, or you can't even grasp the leaflets. And finally, location of the pathology doesn't matter. This is important. When we started CRD, we only used to do middle A2P2 disease. And now it doesn't really matter. You can do a flail anterior leaflet in the lateral part, or the posterior part, or the middle. So it doesn't really matter. When it comes to just overall, there's about, it's only transcatheter mitral valve repair option in US and Canada. Am I correct about that? In Canada, do you have any other options?
No,
Nothing else.
but it's not
But
approved.
Pascal is only
not approved. Yeah.
not approved.
Yeah.
60,000 cases done worldwide, so if there are any non-believers in the audience, it's too late. And in the US and in Canada, it's been approved for primary degenerative MR. That's important. That was the question, who are at prohibited risk for surgery. And the reason why I'm saying this is that worldwide, out of the 60,000 cases, probably 40,000 of cases are actually functional MR, especially in Europe, right? But there are clinical trials just being completed on functional MR, which I think is the biggest indication, which will be out literally in the next 3 months. You have to choose your imaging specialist. This is very big, because this is a procedure which you can't do by yourself. And the echocardiographer is as important as you. And in fact, this is a cardiac anesthesiologist who actually does the procedure with me. And I think if he was not there, we wouldn't be able to do this procedure. So that's important. The transeptal puncture is critical, and I actually want to correct your slide, Mark. And I remember everyone keeps on saying that the transeptal puncture has to be high and posterior. But with the NT, that doesn't work because you look at a wall hug. There's too much to detail the procedure, but just I want to tell you, you should be mid-fossa in the bicaval view and posterior in the short axis. Because if you go with the NT, and XT, the original one is going away. So you should use this as, because otherwise what happens is here, you get a wall hugger. It goes down from the anterior to posterior. You can't get coaxial. So it's better to be in mid-fossa in the mid, and very posterior. And the higher you get, higher means distance is better. So I would say go to 4.5 to 5 centimeters. Don't stay even less than 4.5. So this is the fundamental difference with the two procedures. The same as with Pascal. This is the second thing which I do differently, which I find is continuous measurement of left atrial pressure. This is very helpful. So what I do is I do a transeptal puncture. I put 2 wires up the pulmonary vein. Over one wire, you have a 4 French pigtail catheter. Over the other wire is the stiff guiding catheter. So you have a constant left atrial pressure monitoring. And the advantage of this is I found, especially in functional MR, if the LA pressure doesn't change, if you put a clip in, why even put the clip in? So that's why I always monitor the LA pressure. And what I find is the V wave often comes down. And that's a very good sign that actually this is being effective.
From the pigtail and the
Through the same,
from the
same venotomy. So I'll
vein, but same guide catheter or side by side?
side by side. So this is what it looks like, Ziad. So this is what the 2 pictures are. But look at that. So through the same venotomy, you have one side a pigtail and one side the guide catheter. But since it's only 4 French, it doesn't bleed. So you get a constant measurement of the LA pressure, and it's so useful.
The pigtail over just the skin, no small sheath in it.
No, directly. And you can see you get a V wave, and it's so nice because you grasp the leaflets and you close the clip, you can just see the LA pressure changing. And if you see no change in LA pressure, then you should not leave the clip behind. Or sometimes when you're going for the second clip, and then you see the LA pressure is going up, that means you're causing more mitral stenosis, then you actually release the clip. So that's what I do in every case. Routinely, every single case. And also it gives you a double access through the FTM. And you don't get the same pressures if you do it from the guide side port of the guide catheter. It's damped. So this is very useful. Then, of course, orientation of the clip. This is critical that you orient the clip above and below because you want to be exactly perpendicular to the line of coaptation. So in the middle of the valve, you should be 6 and 12. On the sides of the valve, you should be probably 5 and 7, like oblique. And if you don't do that, this is what happens. So here's a patient who's got a flail P2 right in the middle, and then we see we put a clip in, but look what happens. When you put the clip in, there's a jet that has risen from the medial side, and that's because you've distorted the valve, because you've not caught it correct, tidal volume. And then finally, you should always look at leaflet insertion in detail. So here you can see, haven't caught the leaflets very well. 10 pulse, low threshold to use a second clip. So if here is an example of a patient with a very wide jet, we put one clip in and you can see that you have a reduction of MR, but you still have a medial jet. You check the gradient, and if the gradient's adequate, then you put a second clip here, and then we put 2 clips in, and you see it's gone to trace MR. So you have a low threshold to put 2 clips. The advantage is 2. One is a better reduction of MR. 2 is the second clip stabilizes the first clip and releases tension on the leaflets itself. So that's why we have a low threshold of putting 2 clips. And so here you can see this is the double orifice with a good adequate orifice size. Combined echo and invasive hemodynamics is helpful for the final result. So it's important, as you can see, when you do combined echo and hemodynamics, each time you put a clip in, you just can't just look at color. You look at color, you see pulmonary vein flow, you measure mitral valve area, you measure the gradient, you see the 3D end face before you release a clip. In addition, this is what I do, invasive, I see a reduction of the V wave or the mean LA pressure, and usually improvements in cardiac output. This is, of course, the last part, but at least reduction of V wave and LA pressure is very important before I release a clip. So I look at both these things, and if both are correct, then actually I deploy the clip. And this is just an example. You can see over here, look at the prominent V wave. Immediately after one clip, you can see what happens to the A wave and V wave. It's come down, and over there it's come down, and see the cardiac outputs going up from 5.2 to 6 liters. So this is a common scenario that you see after you do the echo as well as hemodynamics. So summarizing, I've been in time, right? Case selection is important. Attention to detail at each step is essential. There should be a low threshold to place multiple clips, provided you have an adequate orifice, and use both echo as well as invasive hemodynamics in assessing of details. And the other thing is that do not put an arterial line in the groin. We never put arterial lines in the groin. If you need one, put just a radial line in. So it just minimizes bleeding. All patients go from the cath lab to the floor. They never go to the ICU unless the patient was critically sick before. And even if the patient has a very low ejection fraction, we don't follow them in the ICU. Thank you very much. Question? Yeah. It's, I think, 920 now in Cedars. So that's the largest experience.
ask
And
the
we are
question?
hoping. I have done 90%.
Okay, so we can now have a quick 5 minutes discussion on this important topic with Dr. Adi Yadav to moderate this discussion.
Certainly. Thank you very much, Dr. Vivek Gupta. It was a wonderful, you have arranged this scientific sessions and wonderfully chosen. And all the speakers have been doing wonderful discussions and over this Mitra clip. Dr. Yadav, you said this transcatheter, this is catheter-directed, steered procedure, which is nowadays becoming successful and very, very common. And this is surgical, where actually the surgical procedure is needed, that is one question. Secondly, you have been talking about primary mitral regurgitation, asymptomatic. Would you do some procedure, and where Alferi is done, and where the caudal repair and all, how do you select a patient? Over to you.
Thank you for the question, sir. First of all, asymptomatic primary MR means degenerative primary MR, where the Barlow's disease like mitral valve collapse, chordae rupture, because chordae tear, or papillary muscle rupture, all this require, even asymptomatic require treatment. Particularly if the ejection fraction is below 60% and LV in systolic dimension more than 40 millimeter diameter. So this is the guideline indicated, even asymptomatic. Because asymptomatic, because it increases afterload, and once you do the mitral valve replacement, the chances of deteriorating the patient leading to heart failure is very high. So they should be treated when the ejection fraction is maintained. So below 60% means LV systolic dysfunction in patient of mitral regurgitation. So this is the regarding the primary asymptomatic. And now LV systolic dysfunction, if the patient is having LV systolic dysfunction with mitral regurgitation, that is called secondary mitral regurgitation. In that case, surgery is contraindicated, because the result of surgery, whatever you do, whether you do mitral valve repair or replacement, the result is not good. Mortality rate is very high. And no better than guideline directed medical therapy. So here, Mitra clip or mitral valve repair, and you know, in patient of mitral valve disease with mitral regurgitation, choice of therapy is mitral valve repair rather than replacement. Once you replace the mitral valve complex, also you remove. You remove the chorditeny, you remove the leaflet, you remove the papillary muscle. So all these important structures get away, and that's why repair is better as compared to replacement. So if the surgeon is very efficient in repairing, ask them to repair in patients of mitral regurgitation. So this is...
And from Dr. Mukesh Goyal regarding this important burning issue. If the surgeon is efficient, he can do the repair rather than doing a repair by Mitra clip. Can we have the mic to Dr. Mukesh Goyal?
So, Dr. Yadav, you have very well pointed out that Mitra clip is tailor-made for secondary MR, where the surgical benefit and risk is very, very high, and the benefit is very suspicious. But for primary degenerative MR, surgical repair, if a surgeon is capable and he thinks that he has a more than 95% chance of repairing it. The patient is low surgical risk. So if the patient is high surgical risk, though the surgeon can repair it, I think still a Mitra clip is a better option for that patient.
Definitely. Though in primary MR, if the surgeons refuse because of some comorbidities, then Mitra clip is the treatment. But for secondary MR, Mitra clip is the first treatment, apart from guideline directed medical therapy. Because of LV systolic dysfunction, surgical mortality rate is very high. And yes, all these are comes in you're recommending the patient for surgery. If the PA pressure more than 50 millimeter of mercury, they all indicate even asymptomatic required treatment. That's why I'm saying symptomatic required treatment. Even asymptomatic required treatment. That is the most important. And should be diagnosed by echo, screening echo and all these things. So in Mitra clip, four, 5 things are important, technical. First, transeptal puncture.
Somebody on Zoom actually.
Stitching the two leaflet, middle part of the leaflet, both anterior and posterior leaflet, that is the A2 and P2 together. That is the alveolar repair. So, first is transeptal. Transeptal should be in the your middle or what is called slightly middle and posterior. So you need two view. You need 3 person. One person who does the transeptal, another manipulating the clip, another person echo. So it's totally echo based. And even transeptal puncture and all procedure is echo based, and 3D echo is a must. And 3D echo with explain view or multi-D view in G, those features should be there. Only then you can do. 3D live T is very, very important. Then you know your trajectory, how it goes inside the LA towards the leaflet. It should be, trajectory should be such that puncture should be such that you have to see 4-chamber view between the leaflet annular plane versus the transeptal place where you have did the transeptal should be measured in around 4.5 centimeter, not more than 5 centimeter. It should be 4 to 4.5 centimeter. So adequate if it is 4 centimeter and above, up to 0.5, but not above 5. So it should be 4.5 or 4 centimeter, so that trajectory falls on the valve leaflet. And second is that totally you have to, based on 3D, how you are moving, you are 12 o'clock, 6 o'clock or not, in the A2, P2 level or not. And you see en-face view, where aorta is up, and on this side is the lateral, that is P1, A2, P1, A1, A2, P2, and A2, P2, and A3, P3. A3, P3 is medial. So here is the medial, here is the lateral, above is the aorta anterior, and on this side posterior. So this view, in en-face view, is very important. And when you clip, you have to see the live T, and here you need LVOT view and bicommissural view. Bicommissural view, and here is technical dependent. Whether you need to move medially, laterally, anteriorly, posteriorly, all knobs are there. By that knobs, you move and grasp the clip. And new version, that is G4, has got independent grasping. Means you grasp either posterior leaflet or anterior leaflet, depending on your need. Say if your posterior leaflet is in range of grasping, you grasp first. And then individually you can grasp, or you can grasp together also. So this is the beauty. And then once you grasp, close the clip, and then found that, and you have to dissect, clip you have to dissect or capture where is the vena contracta, where vena contracta of the mitral regurgitation. So mitral regurgitation goes up bifurcate the vena contracta. Then it will decrease the mitral regurgitation. So these are the important points. And as Dr. Saibal has shown here, you must keep a 4 French pigtail inside the LA, continuously monitoring the LA pressure and V wave. So once you will clip it properly, V will decrease.
Where do you do transeptal puncture?
Transeptal puncture should be in the middle of the septum and posteriorly. So you need two view. One is the bicable view and the short axis view. Short axis view posteriorly and 4-chamber view to see the height from the annular plane. If the so 3 view required for transeptal in TE guided. One is bicable view for puncture at the middle of the septum, and short axis view posteriorly, and 4-chamber view to know the height from the puncture needle to the height of the annulus. So these things are.
Thank you very much, Dr. R.D. Yadav. I would request you to stay back for a very wonderful session you have done. We move on to the next symposia, which is coronary intervention. We'll have a lecture or recorded lecture from Dr. Sigvard, who is the father of stenting, Dr. Antonio Colombo, who has done huge work in Italy, and myself. So the 3 talk. I think let us have the same people to sit there, and Dr. Amit Munjal will speak about the drug-eluting stents, drug-eluting balloon after that. So let me start my talk. We'll have a coffee break after the symposia, and then we'll have evening cultural program. So we request all the doctors who are here to stay back for the cultural evening valedictory function. So can you put this slide there? So what I'm going to talk about is evolution of the coronary angioplasty and stenting. Can we have my picture here, picture in picture? Okay, so we know that angioplasty started in the year 1977. I think you would like, Dr. Adi, you would like to hear all those things. The first angioplasty was done in Zurich, 1977. And this was Andreas Gutzig. At the same time, Adolf Bashman also did it, but the publication came first from Andreas, so he is known as the father of angioplasty. He's just a fellow, he was just a fellow working in Zurich, and he did balloon angioplasty. After that, he became a hero. And to that extent that America actually hijacked him from Zurich to US. He had an early death actually, and he had a charter plane at that time. He was a very big man, because the angioplasty started by him. And he had a plane crash, I don't know, I think less than around 40 or 45 year age. He would have been living by this time, if he was there, 90s, something like that. The first PTCA, September 16, 1977, Zurich, and these were the ingredients. I mean, this is for the joke, but he used very different kind of catheters. Once you are doing innovation, you have to be, very brain idea should be there. And you can see the angioplasty, first angioplasty was the left main stenosis. RD would be knowing this. And after 77, and it was a plain balloon angioplasty, 87, the artery was still open. Acute closure. What the problem was that this angioplasty was being done from 1977 to 1987, continuously by various procedure operators. In India, of course, there was a beginning. And I don't know, first angioplasty in India was done by Dr. Samuel Matthews, I think, as he claims to, from Chennai in Apollo Hospital. But problem was this, that whenever you're doing balloon angioplasty, there were 5 to 10% chances of acute closure. Acute closure means you put a balloon, open and after a few hours or 1 or 2 days, the artery will close down, it will lead to acute MI, heart attack. To prevent acute closure, bare metal stents were developed. You can see the old Cook's JR Palma Shard stent. We have used one of them, few of them. To raise stenosis, then after this, the problem was that bare metal stent was developed, and the first stenting was done by actually Dr. Sigvard. I'll have a lecture of Dr. Sigvard, and he did in Lausanne, again in Switzerland. The first angioplasty in Zurich, Switzerland, and first stenting in Lausanne, again Switzerland. And there's a cath lab by the name of Dr. Sigvard Cath Lab. I visited the center. I'll show his lecture after this. So, but the bare metals was problem, but the restenosis after bare metal stent was another problem. That means 20% to 30% patients will have recurrence within 6 months. And that was a problem, and that is why drug-eluting stents were developed. This was the first generation drug-eluting stent, then with polymer, polydefined, a lot of innovation have happened during this velocity stent. We have used BX velocity. Then that drug which was being used for the purpose of prevention of restenosis was paclitaxel and sirolimus. They have a property of inhibiting the neointimal proliferation. They were actually anti-cancerous drugs, and they work by inhibiting the neointimal proliferation, and this was done. Sirolimus stent 7-year follow-up was seen, and they found that the restenosis was almost less than 5% or 2%, from 20 to 30%. The target lesion revascularization was also less at 5, and the Texas trial, which was done by Craig Stone, who was speaking about OCT in the morning session. And the drug-eluting stent thrombosis, late thrombosis, but the problem was still there, that late thrombosis was still there, therefore different types of polymers were being used. And Dr. Mukesh Goyal, I would like to just sit back for a while. You can't, unless you have a person to operate, because you have to chair another session after this. Okay, so we had a polymer, the drug and the stent. Different type of designs were being used, SPRIT 2-3 trial, multiple trials, randomized trials happened to further eliminate early and late stenosis of thrombosis and stenosis. I have borrowed these slides from Antonio Colombo, and I spoke to him, he sent the slide to me. So I would like to repeat what Colombo has to say. Antonio Colombo is one of the very important interventional cardiologist and very aggressive cardiologist. Aggressive means he has been doing a lot of complex cases. Our good friend, he works in Milan. Milano, they call it Milano, actually it's Milan in Italy, and he also does a lot of courses. So these are slides which he has given to me by WeTransfer. So you can see that Andreas Gunzig, again Simon, Richard Myler, the first intraoperative PTCA performed there. Jeffro, the 1946, Hartzell also did the same time, and complex balloon angioplasty, primary angioplasty for acute MI was done by him for the first time. Then this is Ulrich Sigvard and Gary Rubin. They devised a new technology for the stenting. I told you that his talk will be there later on. And 3 years after first implanted IMO Group Columbus, 1992. This is IMO Hospital, IMO Center Columbus in Milan. So this was done by them. Intracoronary stenting without anticoagulation accompanied with intravascular ultrasound was circulation 1995. These were early days of drug-eluting stent. 1993 actually, drug-eluting stent came in 2001. Early days of stenting. That time ticlopidine was being used, aspirin plus ticlopidine rather than clopidogrel. This is historical aspect. And then came drug-eluting stent, pooled patient data by various registries published in JACC in 2022 show that 2,057 patients, 2,500 patients with long lesion treated with implanted long length. So these are various type of publications, ESC 2023 by, so why most operators stent every lesion to be treated? Among many reasons, the most important is to prevent sudden closure when the result is not stent-like. The stenting is actually not only to provide a prevention of restenosis, but also to prevent abrupt closure. As I told you, that stabilizes the plaque and there is no acute closure. These are the few cases which he has sent to me. As you can see, the wiring in the LED, then the branch, the diagonal is actually bifurcation lesion, and after this after bifurcation lesion, LED diagonal bifurcation lesion. And this is a OCT analysis and IVAS analysis. This is a long diffuse case of RCA, initial angiogram and final angiogram. You can see baseline. Another case is not working. So to finalize my talk, the randomization that angioplasty has been now being done in long lesions, complex lesions, bifurcation lesions, long stent, triple vessel disease, 3 stents, 4 stents. I have experience of doing more than 5 stents in one sitting, but normally if there are more than 4 stents required, we do the stage angioplasty. So stent renosis is low. Nevertheless, PCI trials demonstrate inferior results compared to bypass surgery in complex cases, but bypass surgery is still an option. But the patient normally wants to avoid bypass surgery, and then we are then pushed to do a complex angioplasty or 2-3 vessel. But we have data now that 3 vessel disease can also be treated very well with the angioplasty if the lesions are amenable to angioplasty. So now I will show you 2 recorded lectures, one from Ulrich Sigvard, and he has done, I told you that he's the father of stenting, and he had sent me this video. Sorry. we can have first okay, so we can have a talk of Dr. Antonio Colombo first, and then we can have a Dr. Sigvard talk. Can we have the audio?
I think the guy support is essential when you try to
This is Dr.
cannulate
Antino
this
Colombo. I
difficult.
was talking about
go
very aggressive cardiology.
immediately with a wire, and as soon as I load the wire in the guide, and as soon as I meet the kids, and after the excellent introductory lecture this morning of Dr. Shah slides, I will skip in the interest of time. I have no conflict to disclose. I think in stable angina, a patient ischemia trial supported the concept of reasonable incomplete revascularization. If complete revascularization is important, is MI. I think ischemia trial has shown that you don't need
Italians
to
have a different way of
revascularize at
accent,
all.
but it's very understandable.
So at least some minimalistic revascularization may be valuable. Sustained evidence that imaging and physiology make PCI better. I think this is we tried to promote this concept for the last 20 years, and now we are getting there. Better lesion preparation, particularly for calcific lesion. We saw several examples in this meeting. And I believe bioresorbable scaffold paved the way to the concept of lesion preparation. So they need to be congratulated for opening the field. And new devices, also lithotripsy, made this success a reality. Introduction of new tests. I will devote 2 or 3 slides about this new DS, metal DS, called bioadapter. Most of DS now 1 month may be sufficient. There is a trend toward dilate the lesion well. So some technology to treat calcified fibrotic lesion were not present. Lithotripsy, orbital atherectomy, or cutting balloon was not fully utilized. So I think if we repeat the AVIO trial now, most probably this 40% will go down to 10%. Approach to calcified lesion, I go fast, high pressure balloon, rotablator, angioscal, cutting balloon, shock wave, and laser. The concept I will make in these few slides is that sometimes you need a combination. It is very difficult to evaluate one device versus the other. This is an example of a calcific lesion, rotablator 175, high pressure balloon did not work. Then we use a cutting balloon. When we use cutting balloon, we go at 24, 25 atmosphere. But as I said, we undersize the balloon 0.5 millimeter because this balloon at high pressure becomes compliant, and with cutting balloon, sometimes you achieve a good lesion expansion. Here at the IBUS crack caused by the cutting balloon with a good final result. Shock wave, you can do really shock wave even in a strange situation. This is an occluded stent. We finally crossed below the, underneath the struts, so noting the lumen, and created a new lumen and crushed the old stent. But because of the calcification, we used extensive shock wave to fully expand. And finally, we reached a good result with this unusual utilization of the shock wave. But again, the value of multiple devices is important. Despite the shock wave and whatever angiographically looks good, the IBUS result is still unsatisfactory, and we were able to correct these only with OPN, very high pressure balloon at 37 atmospheres. So it's not rare that we use this device after the shock wave. The problem we saw in the LAD that was treated by Kimi is this focal calcium. This focal calcium is very difficult to be dealt. Shock wave many times does not work, most of the time does not work. Maybe orbital atherectomy, but we don't have experience with these devices. So the final result is most of the time asymmetric. Even in this case, Wolverine at high pressure, 24 atmospheres did not succeed. And after stenting, you see this reasonable result, but not an optimal result. And you see that there is still some sign of the balloon incomplete expansion. But, you know, I think there is nothing you can do, and you have to accept, but maybe some new technology will take care. 3 slides about this new stent is available in Europe, maybe soon will come in US. Is a metallic stent DS where the link in the coronal plane are detachable. The polymer after 6 months reabsorb and the stent is able to expand. So this is the stent after 6 months. You see that there is a lumen gain in systole and in diastole of about 14.9% because the stent becomes loose and there is no more jailing of the vessel wall and allow positive remodeling. This is a schematic view of the stent. Standard stent, you see that they are same and the only difference is the hyperplasia. With this bioadapter, the link break open, to say a better word, and you have a positive remodeling of the vessel, which may be able to accommodate hyperplasia. So the final lumen is at the end a little bit larger. This advantage is also translated into regaining of the anatomy because there is no more straightening as a follow-up. We did a mechanistic study with Dr. Verein, 50 patients published in Neurointervention, and there are other studies. There are 2 big randomized studies, one in Sweden and one in Japan, comparing this device to standard metal stents. But what are the open issues for our future? This is why PCI keeps on failing in complex patient versus bypass. A lot of patients we saw today, maybe if we were treated by a very good surgeon, would have done better. Because I think PCI in complex patients is still inferior to bypass. Is the issue related to the patient or to the lesion? I think it's related to the lesion. Should we be considering stenting the only approach? Maybe stenting is not the default approach in every lesion. Any reason to resurrect bioresorbable scaffold? And the saga on diabetic. Diabetic is the protective role of mammary on the proximal LAD. These are all issues for the future. I recently showed the 60-year-old gentleman, I will show the angio, and I recommended bypass. Should this recommendation become the standard in this type of anatomy, or maybe in 5 years we can think differently? Look at this, is the left main with a bifurcation of the circumflex. It's a nasty with a lot of diffuse disease in the circumflex. The bifurcation is not a simple one. There is another diffuse disease of the LAD and the right coronary artery. The patient is diabetic. So I think this is a straight bypass. Can we see in the future any change, or we have to accept that this type of patient should go to bypass and period? I don't know. But the point I like to make is that when we have focal lesions like the one in this graphic, stenting is ideal. But I'm really questioning the idea to treat with long stents this diffuse LAD. So I like to propose, and I hope next year to provide you some data, that stent and drug-eluting balloon together may be a better solution for this type of lesions. Large vessel,
this conference is actually a hybrid conference, so we have going Facebook Live,
20,
hybrid Live, Zoom.
25, 28,
So
you pick a number.
Conference will
But
be
in long
remembered for a long
lesion
time.
with diffuse disease, we should use the same approach and use long stents like we saw today, or should we propose something else. You will see some example of optimal lesion preparation, maybe stenting proximally, and then IVUS and FFR evaluation, and then use drug-coated balloon. I don't believe that this type of result apply to contemporary interventional cardiology. Long stents or totally occluded, this patient cannot be treated. You can reopen the stent, but they will restenose for sure. An approach here is an example. This is a bifurcation LED with a big diagonal, a lot of disease. This long diagonal, if stented 2.5 with a 38, almost always restenosis. The only way to prevent restenosis in this long diagonal is to avoid angiographic follow-up. That's a guarantee that you prevent restenosis. Otherwise, restenosis is guaranteed. In this case, we stented the LED, and we did ballooning of the diagonal. I see that there is a dissection, but the PDPA, all concept of Grunzig, was only 11 of gradient with a pressure wire very distal, and we did drug-coated balloon, and patient did well. This is another example. You see an LED with a severe lesion proximally, a lot of diffuse disease distal. We did the stenting proximally, but distal was a suboptimal result. We measured the pressure, is still significant. We did further dilatation with a 2.5 balloon, and then PDPA was 94, contrast FFR 88, and we elected to use a drug-coated balloon 40 millimeter with a very reasonable result. So I think this is not to go against stenting, but to give an aid to stenting in situations where stenting may be suboptimal. There is even an emerging role of DCB on the side branch, and in some settings, only in some, even in the main branch. This is the case we did recently, complex bifurcation. We did pre-dilatation, the usual stuff, and then we did kissing balloon, and then after these we did DCB, and we didn't place a stent. The reason why we took this decision is because when we measured the gradient in the LED, there was 0 gradient, was 1 PDPA, and on the diagonal was 95. So it's rare, but sometimes an excellent result, even if there is a dissection, can be accepted. 91 very distal in the diagonal, and 1 so means 0 gradient in the LED. So it's maybe this is too much, but sometimes you don't need a stent. So I conclude by stating that PCI needs to evolve. A stent, one type of stent, metal, bioabsorbable, bioadapter, etc. A drug-coated balloon, one single device may not fit all. So we need to be a little bit innovative and combine different devices in the same patient. And in some situations, we have to resurrect hybrid with bypass surgery. We saw several cases today where a good mammary on the LED would have been perfect, maybe even a mammary and a drug-coated balloon to improve distal flow. I know that these are not so practical solutions, but if I were a patient, I don't care if the solution proposed is practical or not. Thank you for your attention.
By Dr. Colombo, who is a master of interventional cardiology. Next, we have a talk by Dr. Sigvard, and then we will have a small discussion. Dr. Sigvard talk is also here, the father of stenting. Dr. Sigvard has been a good friend and a very senior person.
How does this?
The person who did the first stenting in the world, 1987, Lausanne, Switzerland.
How does this go ahead?
I was
I'll
a
try to give
faculty
you
in many of our ICR conferences.
a few ideas about what I think about angioplasty and a few tips and tricks as announced. Well, this is just the introduction how to do angioplasty. As we have just heard by Professor Vogt, the method was introduced in 1977. Everyone knows that. And this man, in the end of 1977, after he had done a few angioplasties in Zurich, handed over 2 balloons of this kind and 3 guiding catheters to me and said, go ahead and try this, which I did. And I published, a little later, my first year's experience with angioplasty, balloon angioplasty, in a German journal, as you can see here. And I'll give you very briefly the account of how badly we did at the time. These were 7 cases that I did in 1978, just after Grünzig had started.
Very important historical
and the
perspective.
Success rate was not even 60%.
First 8 cases.
We tried, at the time, we were so careful. We tried to inflate the balloon only for 10 seconds or so. And the balloon would not withstand more than 5 atmospheres. And we ended up together, these are the pool data with Grünzig and myself in 1978. We ended up with a success rate of about 80%. Close to 5% acute myocardial infarctions, 2.5% emergency surgery, and 1 in 3 clinical recurrence. So we had to tell the patient there is a good chance that you will be back. And the surgeons were quite happy about this because they considered angioplasty a big mistake. Now, 2015, almost 40 years later, we have more than 98% success rate for single lesions, a less than 1% acute myocardial infarction rate, a less than 1% emergency surgery rate, and less than 5% angiographic recurrence rate. So does that mean that there is no place for CABG anymore? I'll be a traitor when I tell you I don't think there is no place for CABG anymore. I think there is a good place for CABG anymore. Consider surgery. It's, first of all, we are using biological material, which is an enormous advantage. And there is proven long-term outcome. A number of studies have shown this. There's a FREEDOM trial where you can see that the CABG group is doing, in the long run, is doing much better in multivessel disease. We're talking about multivessel disease. I'm not talking about one single stenosis, but this is multivessel disease. And there is a very recent trial, the BEST trial, from South Korea, where they love angioplasty, which shows that the surgical group does better in regard to myocardial infarctions and in regard to myocardial infarction and other parameters as well with coronary artery bypass surgery rather than angioplasty. So you can condemn me. I'm probably in the wrong place here, in front of the right audience. Surgery is not such a bad thing. This is no longer the way to do. This was 60 years ago when the patient had to be cooled off before surgery in a bathtub with ice, terrible things. No longer is this being practiced. Surgery is now a method which works extremely well, and the patient can be treated the way that he doesn't keep a very bad souvenir. Now, let's briefly talk about my first 1,000 cases of coronary angiogram I've done from the arm, but I think there are advantages to both sides, and I'm not at all fundamentalist about this. One should use the access that one feels comfortable with. That's my opinion. You can correct me on this. Then, of course, we have closure devices now and compression devices, and one can also talk about heparin reversal, but this is no longer an issue, I think, with the closure devices that we have at hand. Now, the coronary artery entry site is a big issue. I think one has to be extremely careful about the entry site, as we have just seen in one of the cases here. One has to make sure that the catheter is strictly aligned, coaxially aligned with the entry site. I've been on meetings of this kind. I've been always stressing this, and I am a sort of a fundamentalist, if you wish. I think it's very important. Then there can be, one should use catheters with an atraumatic soft tip and a soft rim. This is one of the key issues for angioplasty. Look at this case here, which I've collected from one of my colleagues in Geneva. He was heading for this lesion here, and after introducing the catheter, he ended up with a very proximal occlusion. This can happen all the time, especially also on the left side, when the catheter points to the roof of the left main and dissects right
so
away.
90% blockage becoming 100% notable. Huh?
Then the lesion itself. Well, no lesion beyond reason. One has to be careful about the limits of coronary angioplasty, even at the time of use of coronary stents. Be gentle, gentle, gentle. That's very important. When I see young angioplasters using force, every time I almost faint. I think it's very important to treat lesions with great respect. I advise against oversizing because the dissection rate is very high, and I would focus on balloon preparation. I've been done this here in this place here many times. Balloon preparation is also important. If you imagine that you have a bubble sitting here, and I see this all the time, looking at life courses, I see all the time balloons being prepped in just a second and with bubbles in the end, which can cause disasters. I've been in court as an expert witness with fatal cases where the balloon ruptured, and with air in the balloon, this can be a catastrophe, rupture of the myocardium, everything. So I would advise very careful filling the balloon with liquid rather than with gas. Then POBA is still on the agenda. It's almost a sacrilege to talk about balloon stentless angioplasty, POBA. But I think putting heavy metal into coronary arteries is always worth a decision. Look at this case we did in this place here, up on the, which floor? Is it the 10th floor? The 7th floor, the 7th floor in 1978. Where we dilated a proximal LAD stenosis and got a very good result. You may argue that this little dissection is a reason to put a stent in, but nowadays with platelet inhibitors and good therapy, this rarely causes any trouble. Now, when you show this to a young cardiologist these days, he said, of course this must be stented. it must not necessarily be stented, and hardware in coronaries require a good reflection. Even the daily press here in this country has recently come up with a statement. The cardiologists put too many stents without any good reason into patients. This was on a Sunday edition a couple of weeks ago. So think about carotid arteries. It is quite clear that the risk of stroke, death, is nearly cut in half without post-stenting dilatation, because the material is being removed once you put a stent a balloon into a stent and squeeze it harder. The chances of embolism of small. Well, we have been not talking about equipment. I heard just before, I heard Morton giving a plaidoyer for the use of automatic injectors at angioplasty. I feel much more comfortable with less sophisticated equipment when for instance, when I slide the guiding catheter along the aortic wall into the coronary artery using hand pressure, like an air cushion, like a hydrofoil, pressure of contrast medium until I'm in there. So I'm quite sure that I'm not shoveling any debris into the coronary arteries. Equipment is not necessarily a great thing. The most sophisticated equipment may not give better results and in the end increase the rate of complications. So simple, simple, simple is my devise. So in a few general remarks, safety first, no shortcuts. Ambition is counterproductive in angioplasty. Consider stage procedures, and the results of stage procedures in multi-vessel disease are better than doing it in one go. And surgery has a superb record. I must remind everyone in this room, there are a few surgeons here, I'm quite sure, but they would be delighted to hear my words. Thank you very much.
I would like to show you the last slide, actually, and just emphasize upon this point. Safety first. When I do angioplasty, and other people, Dr. Amit will agree, that more important than success is safety. More important than success is safety. Because finally you are operating on a patient who is not anesthetized. So you have to have, actually, to avoid complication, the most important thing is that you should foresee complication. Amit, just listen to me, it's very important. If you foresee complication, then you will not have complication. So this is very important. My technician always say, I tell him that balloon size ye de do, chota de do, bada de do. Kehte, you are very cautious. I said, because I am cautious, that's why I don't have complications. So you have to be very, very choosy, and you should actually follow the copybook style. You should be Sachin Tendulkar or Sunil Gavaskar rather than Virendra Sehwag, because Virendra Sehwag can afford to get out, but you can't afford to get out on the zero because the patient life is important. Here the patient life is involved. So you have to be copybook style angioplasty. Ambition is counterproductive. That means don't try to do too much. So when I do angioplasties, I always say minimum governance and maximum government. This is Narendra Modi's style. Minimum governance and maximum government. That means that with using minimum of lesions, you should have the maximum revascularization. So don't try to chase small diagonal, small OM. So that is actually a waste of time, and it is causing, that actually compromises safety. Consider stage procedure, very important. Whenever there are 4 blockages, or primary PCI, it's very important to do only the cases actually culprit vessel. So if there is something which I can avoid, I always do stage procedure. I tell the patient, for me important is safety, and therefore I'll do the next procedure after 4 weeks, 3 weeks, not necessarily in the same discharge. Surgery has superb record. This is something, of course, There are few trials which have shown bypass surgery is better with low ejection fraction, triple vessel disease, left main. Why I'm talking about this going live also, it will be recorded. So left main, triple vessel, poor ejection fraction, diabetes. Some surgeons have some records of that. The data has shown that they have superb record. But I personally feel that after doing angioplasty for last 25 years, I feel that angioplasty is no less. Angioplasty with multiple statting, multi-vessel disease angioplasty with the optimal revascularization is no less, and therefore you avoid bypass surgery as much as possible. So this is the conclusion of this. I would like to have a one, Dr. P.C. Rath will like to talk now, or Amit, you would like to talk about drug-eluting balloon now? I'll just talk Dr. P.C. Rath. He's doing live from. If we can wait, I think better to do your case. You have slides given here? So I think Dr. Amit Munjal will talk about drug-eluting balloon, and I request him to just, because we want to finish the talk, to two more topics of, so after 10 minutes? After 10 minutes, okay. So Amit has come all the way from IECR. He was, again, because of fog, he was late. A good and dear friend. He has a lot of respect for me and equally from my side to his side. And he's an interventional cardiologist trying to develop something new from Delhi, but now he is working in which hospital? Your own hospital? Yeah, Umeed Hospital. Okay, in Hisar.
Good evening, everyone. I am Dr. Amit Munjal, practicing as an intervention cardiologist in Hisar. Today we are going to discuss about the use of DCB in ISR and de novo lesions, how and when to use DCB in ISR and de novo lesions. I thank Dr. Vivek Gupta, sir, for inviting me here. These are the fellows of DCB Academy, and I am one of the proud fellows. Learning objective of today's talk is to know which kind of vessel with the de novo lesions could be considered for a DCB alone PCI strategy, to know how to prepare the vessel, deliver the therapy, and evaluate the immediate results after DCB alone PCI, to know about safety and long-term results. First revolution in intervention cardiology was POBA. POBA revolutionized the coronary revascularization, but it has its own limitations in form of vessel damage, acute recoil, dissection, and negative remodeling. This leads to invention of bare metal stents to overcome the POBA shortcomings by providing scaffold support to the arteries. But they have limitations of instant renostosis.
I'll request everybody to stay back because there will be valedictory function and then followed by cultural program also. Sorry.
No problem. As Vivek sir also told, BMS has a 50% rate of instant restenosis. So because of this, there was an invention of drug-eluting stents. These are developed to reduce ISR by releasing medication that prevents excessive tissue growth. But they have limitations of late stem thrombosis, neo-atherosclerosis, and this leads to the invention of drug-coated balloons, leaving nothing behind. Drug-coated balloons are medical devices used in angioplasty, these are coated with medications. DCB angioplasty is, you can see here, artery is blocked with plaque deposits, balloon is inflated for 90 seconds, and the drug is transferred to the vessel wall and artery is opened. Treatment of ISR. Drug-eluting stents are recommended for treatment of ISR of BMS or drug-eluting stents. Drug-coated balloons are recommended for the treatment of ISR of BMS or DES. In patients with recurrent episodes of diffuse ISR, CABG should be considered by the HERT team over a new PCI attempt. Clinical applications of DCB in coronary artery disease. Drug-coated balloons are proven effective in treating ISR and native small vessel disease in coronary arteries. DCB are expanding to new applications, including treatment of bifurcation lesions, large vessel, and diffuse disease, and in situations with high bleeding risk. ESC guidelines recommend DCB as a treatment option for both bare metal and drug-eluting stent restenosis. Some key studies and trials on with DCBs. basket small 2 results. Nearly 800 patients with de novo lesions in small vessel. DCB was non-inferior regarding MACE at 1 year. Picoletto 2 studies. It is drug-coated balloon versus drug-eluting stent for small coronary vessel disease. Here in late angiographic follow-up, late lumen loss was actually better in DCB group. More you gain, more you lose. At the end, percentage diameter stenosis was similar in 2 arms, which was confirmed by angiographically. DCB performance in acute coronary syndromes. The Revelation study adds to the body of evidence suggesting that DCB may be a viable alternative to DES for specific patient subset with STEMI, showing comparable results in terms of patient safety and clinical efficacy. The non-inferiority of DCB absorbed in NSTEMI patients indicates that DCB could be an appropriate choice in setting where stent placement is problematic or not preferred, which warrants more attention and study in this patient's population. Hybrid approach, combining DCB with drug-eluting stents. Drug-eluting stents for proximal lesion, DCB for distal lesions. The hybrid approach of combining DCB with DES has been evaluated in long de novo lesions and diffuse coronary artery disease. This approach employs a DES implantation in the proximal lesion and DCB in the distal lesion. This ensures an overall reduction in stent length, which in turn might be beneficial for lowering restenosis rates. Here you can see the hybrid approach of DCB in proximal lesion and DES in proximal lesion and DCB in distal lesions. Here the same hybrid approach is shown for DES in proximal lesion and DCB in distal lesions. The Eastbourne registry. This is done to observe and evaluate the performance of sirolimus coated balloon for the treatment of any type of coronary lesions, including massive vessel disease and instant restenosis. This is a prospective multi-center spontaneous clinical registry, centralized clinical event committee, 2,000 real-world patients, all-comer patients, consecutive enrollment at 35 European and Asiatic sites. Clinical follow-up of 36 months. Primary investigator is Dr. Bernardo Cortes and Dr. Antonio Colombo. Study endpoints. Primary endpoint is TLR at 12 months. Secondary endpoint is procedural success. MACE at 6, 12, and 24 months. Every single element determining the MACE endpoint. Sirolimus coated balloon has very good safety profile and efficacy profile, safe to use in very long and calcified lesions. Meta-analysis of Daedalus trial. 10 RCTs, 2,000 patients, good results with DES and very good results with DCB. With DCB, we avoid another metal layer. The conclusion is drug-coated balloon is new revolution in the field of PCI. Currently, DCB is considered feasible, safe, effective, which has been validated in several studies with more in progress. The efficacy of DCB is now proven, especially for ISR and small vessel disease with a good safety profile. This is a pic from a DCB workshop conducted by Professor Bernardo Cortes in Bathinda, Punjab. Thanks.
Dr. Amit Munjal wonderfully deliberated. As I was having discussion with you related to DES, where you use proximally, and DCB you are using in the distal or small.
Yes, sir. This
artery.
is a hybrid approach.
Then you said that the reduction of stent, what actually will that benefit?
Because of this hybrid approach, we avoid putting long stents, and long stents are more prone to instant restenosis. That's why we can prevent ISR by using this hybrid approach.
You put these patients onto dual antiplatelets.
Yes, but sir, with DCB alone therapy, you have to give antiplatelets for only 1 year.
Only 1 year.
1 month, sir.
1 month.
For drug-eluting stents, we give for 1 year.
1 year you have to give it.
Online? Is he online? Dr. P. Sirath, can you hear me? Yeah, I can see. Dr. Rath, can you hear me? I'm trying to put on your slides. Actually, we could have done a little late. Dr. Rath, can you stay back? Can I do an initial introduction of my... Hello? उनको आवाज नहीं आ रही. Hello? Can you hear me? Dr. Siddharth is here. Okay. Can you come to be a part of the panel? Dr. P.C. Rath, can you hear me? What I will do, I will start my presentation, and he can be at that time chairing the session. And Dr. Rath, can you stay back for 15 minutes, 10 minutes, so that I can do initial introductory presentation?
Hello.
Yes.
Hello.
Hi, Dr. P.C. Rath, can you hear me now? Hello? Dr. Rath? I think you can be, I will, with the permission of Amit and Dr. Israni, what I'll do, I'll start my presentation, then he will take over. This will be introduction to TAVI. So we move on to the next session. We'll have a live in case by Dr. Praveen Chandra, who is being represented by Dr. Siddharth from Vedanta Hospital. And Dr. P.C. Rath will speak a little later. Let me start this talk. Transcatheter aortic valve implantation. It's a very important topic, hot topic of the today's conferences. So I will do this presentation quickly in 10 minutes. Dr. P.C. Rath?
Yeah.
I would
Can you
like
hear
now...
me?
Good evening. Can you stay back for 10 minutes just to introduce...
Yeah, I can stay back, but can you hear me?
I can hear you now. I can hear you.
Okay, okay, fine. You can stay.
Can you see can you see our slides? Hello?
Your slides. Go ahead, please.
Okay, okay. Good. So transcatheter aortic valve implantation, you may not see too many heads here, but since it is going YouTube live, Facebook live, and it's a Zoom meeting also hybrid, so I have no hesitation in going to speak about this topic, and actually this will be recorded and then circulated to many other YouTubes and other places. So transcatheter aortic valve implantation means non-surgical deploying the valve. So it is basically for physicians and other people also to understand. The first in man, a vision by the pioneering team, Alain Cribier did it in Rouen Hospital in France. And that was 16th April 2002. So we have already celebrated 20th year, but this is a very, very important one. I had a privilege and opportunity, and I would say my good fortune that I worked with Alain Cribier from 1996 to 98, and before that, in 93, Dr. P.C. Rath, who is in the panel, he also worked in Rouen, in Charles Nicolle hospitals. He was, I think, the first fellow to be trained by Dr. Cribier. I was not the first one, but I stayed a little longer, almost 2 years, and have a good friendly relationship. As you can see, my son Chinmay on the left side, Dr. Cribier at my Sarita Vihar residence in Delhi, and this is in one of the ESC meetings. So good photographs and my wonderful stay here. And this was the first Indian patient of TAVI in Rouen, with the patient who actually we flew from India in 2011. Actually in 2011, TAVI was still not available in India. It was not introduced in India. So we had to really get this patient done. And he lived for exactly 9 years after that. And then recently he succumbed because of the kidney disease and other things. The scope of presentation of degenerative valve stenosis. Degenerative aortic valve stenosis is the most common acquired valvular heart disease in adults. 26% population over the age 65 has mild to moderate or severe aortic stenosis. 2% is symptomatic and should require treatment. 26% population. And out of that, 2% are symptomatic. That means a quite big number, especially with the aging population And by the estimated that within 10, 15 years, the number of AS patients will nearly double. In surgical valve replacement, that means open heart surgery, valve replacement, is already has been a standard of care for decades. In standard patient, mortality after AVR is low. Mortality and morbidity increase in patients with associated risk factors like age, depressed ejection fraction, but after successful valve replacement, patient lifespan returns to that of general population. This is very important. That means once you do aortic valve replacement, surgically or non-surgically, the patient life is almost normal. What is balloon aortic valvuloplasty? Developing TAVI, a long road littered with pitfalls. The first case of balloon aortic valvuloplasty was also done by Dr. Alan Crebier in 1985 in Rouen. Development of two successful innovations for the surgical, the first aortic balloon valvuloplasty. You see, we do balloon mitral valvuloplasty, but aortic valvuloplasty is always challenging because the coronaries are getting involved and the aorta supplies the blood. So when you inflate the balloon inside the aorta, has to be very, very tricky. It has to be very fast. Otherwise, the patient can also die on the table. So a rational attempt to solve a major unmet clinical need, a single goal of these two linked on innovations. In 2000, 1/3 of symptomatic AS, non-operated, and mortality at 80% at 2-year follow-up. So this was actually for the surgical valve. In 1980s, 50% turned down for surgery. Age per se, more than 70 was an unusual seen in surgical valve replacement. The first aortic balloon valvuloplasty was a patient, first in man, September 1985, published in Lancet, done by same hero, my hero, and actually hero for many people, and Dr. Alan Crebier, and Lancet published in Lancet in 1986. Overnight, he became one of the very important cardiologists when he did in 1985, and they found that although it is useful, but it does not have a long-lasting results. So 40 years after BAV is still alive because that is still required before doing a TAVI procedure. So 15-year road, as you can see, Dr. Crebier, the BAV 1987, Project Balloon Expandable Standard Valve, first announcement, Rouen Landmark Study 1994, published, and then of course they started doing work for TAVI, and they had some 1994, they developed system like this. The valve structure, biological polymer, looking the sponsors for the company, 1994 to 1998, a very important comment I would like to take. They were looking for sponsor. Whenever you start doing an innovation, you need a sponsoring company. And the same Medtronic company, the same company Edwards, they had ruled out completely, telling that this is something impossible, just forget it. So this is what Dr. Crebier shows on the faxes he received from this company. And the same company are now selling hotcakes of TAVI, Medtronic, and Edwards. They had completely ruled out that this is impossible, don't do it, forget, this is the most crazy idea they have ever seen. So creation of PVT was a company which started doing this valve because it was already ruled out, completely ruled out by Medtronic and Edwards, which were a big company in that time. So PVT heart valve was developed in 2000, and then of course preclinical evaluation, extensive in lab and in vivo testing, sheep model. They did a lot of animal testing in sheep, and then they did the first in-man, moving from dream to reality, first in-man implantation of percutaneous aortic valve in April 16, 2002. So FIM TAVI, this patient is very important. The 16th April 2002, 57-year-old young man, cardiac shock, EF of 12%, aortic valve area 0.6 or 8.7, bicuspid valve. The bicuspid is being done, we'll talk. Bicuspid valve TAVI is still a little challenge, and Dr. P. Sirath is going to talk about this only. Multiple comorbidities, acute leg ischemia, no femoral access, failed transseptal BAV. Failed. TAVI was the last option for unplanned transseptal approach, and patient was almost dying. And this was, you can see the eyes of Dr. Crebier and the team, Christophe Tron and Hélène Alcharinov, who are their associate, and I had a very good team working when I worked with them during that time. The valve in place, and you can see this patient immediately 1 hour or 2 hours after the valve implantation, and you can see the gradient going down, and the patient 7 days after, day 8, the patient is still in the hospital in Rouen and published in Circulation, very important journal. So this was how the FIM, the TAVI, was developed by Alan Crebier. The echocardiography, you can see the dream comes true. They said the post-TAVI normal function, aortic valve area from 6.5 to 1.6, confirmation of our 1994 anatomic observation, the valve can work. The first imminent series were published, and that was 4 imminent death, transseptal approach in most of the cases from 2002 to 2005. And then, of course, the first of TAVI offshore, that means TAVI was being also done by many out of India, out of France, and Then, of course, Dr. Mohar, Dr. M. Mark, John Webb from Canada. So it was Crebier Edward valve initially, because the Edward had already bought PVT. PVT, the percutaneous valve technology, was the name of the company which innovated the idea. And then this was later on purchased by this, and Edward Sapien became the valve. So the launch of the concurrent devices at the same time in 2005 by Herbert Grube, and they started working on self-expanding valve at the same time, which is not being sold by Resolute by the name of by Medtronic company as Evolute. And so from 2005, no one could have predicted the prodigious expansion of TAVI over 20 years. The reason for success is continuous and rapid technological improvements, making TAVR easier, faster, and safer. I want to tell you that first case which we did, first case from India, took only 40 minutes in the hands of Dr. Crebier at that time. No journal anesthesia. I would like to show that slides before I finalize my talk, because Dr. P. Sirat is waiting. The reason of success was that 2 operators, 1 fellow, 2 nurses, 1 mid nurse. So that means it has been done by, then of course, America, Martin Leon. They were initially partnered with PVT. Dr. Martin Leon, who is the director, co-director of TCT conference from New York. He was already there, and they did the trials by the partner 1, partner 2, partner 3, and these trials confirmed not only initially they confirmed that non-inferiority, and then partner 3 has shown even in low-risk patients. Earlier they were doing only high-risk patients, that means the patients who are high risk for surgical aortic valve replacement. Then they showed that even in low-risk patient, TAVI is feasible and no less than surgical valve replacement. So 2019, the hypothesis of TAVI, most important, FDA approved TAVI in low-risk patients more than 65 years. And I was talking that Medtronic, Evolute, and Sapien 3, they all both have been approved by this. More than 30 lakhs TAVI have been performed worldwide. Sorry, 1, 2, 3, 4, 5, 6, 3 million. 30 lakhs cases were performed in more than 80 countries. TAVR market has grown, continuous expansion of TAVI. And then I will show you few slides because I have to skip this. These are very comprehensive presentation. This is a very important slide. TAVI, a long journey. You can see 1985 to 2019, partner 3, expansion of all comers. It was FDA approved earlier in CE mark. CE mark is like DGCI in India. DCGI is something like CE mark in Europe. And then of course FDA also approved it. And then FDA approved in the cases also of low-risk patient. So 37 years since BAV, 20 years since FIM, first in man, and this was this. So I would like to show you a few of the presentations of my slides regarding the first case report. This was the 83-year-old man who was treated by TAVI in Rouen in November 2011. Severe aortic valve stenosis, valve area 0.7, P greater than 55, ejection fraction well maintained, hypokinesia of left wall. He was a previous bypass surgery patient, long diabetes mellitus, nephropathy, and he was actually rejected by one of the many surgeons in India. And surgeons referred to me because he knew that I have a relationship with Dr. Crebier, and he will accept this patient to be treated in Rouen. So we did the initial workup in Delhi Apollo Hospital, especially the MRI and the sizing of the valve, and then we did this valve procedure. I will show you the last slide, this one. This is how the valve is being deployed, the first pigtail catheter. This is a common thing now in India, but I wanted to show you the first case, crossing the valve, aortic valve, doing the balloon dilatation, and then of course implanting the valve. At that time, Edward XT valve was available in 2011. And you can see that the valve is going up. You see the valve which is going up. You can see the valve which is going up. It is not a retrograde approach, but antegrade approach. Now nobody is doing retrograde approach. Sorry, this is a retrograde approach, not the antegrade approach. Initially, when Dr. Crebier did the first one, that was through the vein, femoral vein, doing the transeptal from right atrium to left atrium, then left ventricle and to the aorta. That was the route which was being taken, a little more circuitous route. But now people are doing with this retrograde technique through the femoral artery and then putting the same stent-like. So TAVI is also like a stent where you put a balloon dilatation and then put a stent in coronary artery. Here you're doing in the valve, aortic valve. You can see this is the artificial valve, which is on Edward XT valve, bioprosthetic valve. And this goes up, and then it's after proper positioning, of course, leaving behind the coronaries. You have to be very, very precise in this. And I can tell you that it was 40 minutes procedure in hands in the same cath lab where I used to work in 1996 to 97, 98. And this was a patient improved, patient was discharged the third day at that time, and there was no general anesthesia. There was only conscious sedation, a small 2 milligram of midazolam, and the patient was, we are talking, patient was okay, and after this. So I want to tell you that TAVI has been a very, very important technique for this. Now I think Dr. P.C. Rath,
Yeah,
would you like to start? This is a 20-year celebration. Dr. Rath and myself was also there in Rouen in 2021. I think it was 21.
yeah,
And,
21.
22.
Yeah,
We have a
22.
live inbox by Praveen Chandra. Can you stay back for live inbox, or would you like to go straight to your talk?
No, I'll go straight for my talk.
Okay. So Dr. P.C. Rath, you can take on screen, and he will be talking about TAVI in a selected bicuspid aortic valve. You see, normally the aortic valve has 3 cusps, but in bicuspid aortic valve, this patient, which was my case, was already a bicuspid aortic valve done in 2011, but he will talk about the nitty-gritties of the TAVI procedure. He could not, he was supposed to come to Delhi, but he had to go to some other place. I think calling from, where are you at the moment? Which part of India?
That's interior Orissa.
Interior Odisha,
So,
okay.
connectivity is not good,
Let me introduce
but
Dr.
I managed to do it.
Pratap P.C. Rath has been a very important cardiologist in Hyderabad Apollo Hospital. He has also done some cases in Apollo Delhi, but at the moment he is the president of Cardiological Society of India. This term is president of CSI. So I'm very happy that he's a personal friend for a long time, and I'm very happy that he has agreed to give a talk on this. So I will have to show your slides myself.
Yeah, start up, because I can only, I'll be giving my talk through the
So
cell phone
can
only
you see your
because
slides?
connectivity is very bad.
Can you see
So
your
I
slides?
No, I'm not able to see the slides,
Can you
but
put
you
the
go
slides
ahead, can you just,
Slides, put the slides here. Or instead of my face, you put the slides. But we should have Dr. Rath also. Can you see the slides now?
yeah, I can see the slides. Thank you, Vivek, for inviting me. Unfortunately, I couldn't come physically, but I promised that I'll give the talk on Zoom, whatever may be. So I was traveling on the road. The connectivity was bad, so I stayed back in a place. Some connectivity is there, so I can give my talk. I must congratulate Vivek for giving excellent overview of TAVI, and must congratulate for him to take his patient, the first patient in India, to take him all the way from India to France, and get it done. So this requires a lot of commitment in the procedure, in the technology, and also commitment to the patient. Thanks, Dr. Vivek. I know you can do many other things. Anyway, my talk is on bicuspid aortic valve disease, TAVI in bicuspid aortic valve stenosis.
Okay, sorry. Okay. Hello? Network. Network at that side. आपने प्रेजेंटेशन दे दिया है उनको? दे दिया?
Recording in progress.
Hello?
Yes, you are back.
Yeah, fine. So, bicuspid aortic valve disease, the most common congenital defect in the adult, is around 0.28 to 0.2% in the whole overall population. But 1 out of 3 bicuspid aortic valve develops, in course of years, develop aortic stenosis or regurgitation. And overall, if you look at this, can you go to the next slide, please? The prevalence of, usually in patients of aortic stenosis, if the patient's younger, probably chances that it may have the bicuspid aortic stenosis much more. So patients with younger patients, especially young patients below the age of 60, 70, chances are 30-40% patients will have bicuspid aortic valve stenosis. But elderly patients, it is less, around 18 to 22% patients. Next one, please. Next slide. So, in the if you see the trials that has been conducted for TAVI till 2000, most of the trials, the earlier trials, this bicuspid stenosis were excluded. That was because people perceived that it's probably anatomically most challenging. So it was all excluded. Initial trials up to 2015, whatever trials was done, bicuspid stenosis was excluded. Next slide, please. Can you see the slide there?
Perfect. We
Are
can
you
see
able
the
to
slides.
see the slides? Okay.
100%, we are seeing it.
Okay. So the first TAVI that was done by TVR, more than 20 years back, incidentally, on that case, patient was a young patient and patient was a bicuspid aortic stenosis, critical aortic stenosis, who was dying, of course, and you see all the results. So incidentally, the first case was a complex case. Young patient with bicuspid aortic stenosis. If you look at the TAVI scenario in India, I just took the statistics in 2021 and 22. Edward had used 220 units. Out of that, 38% were bicuspid. In Merrill, they have used in 22 800 units, 34% were bicuspid. Medtronic in 2020, they have used 700 TAVI valves, 38% bicuspid. So all this in India, the percentage of bicuspid out is very high, around 38%, up roughly around 38%. Whereas in the elderly patients, it's less. And if you look at the statistics of US or Europe, is around 20%. So incidence of bicuspid aortic stenosis is very high in Southeast Asian countries and is around 38%. So we are going to see more and more these cases. And the challenge in bicuspid aortic valve disease is the abnormal cost fusion. And there is a pronounced asymmetry of the valve orifice and annulus, heavily calcified and fibrotic leaflet, calcified raphe, and enlarged ascending aorta. These are the challenges, anatomical challenges that we see. And bicuspid valve disease can progress to severe aortic stenosis in as little as 10 to 12 years. So these patients are to be followed up every year, but they degenerate very fast and they progress very fast. And whereas tricuspid valve takes longer period, around 20 to 30 years. Can you go for the next slide, please? Okay, this is the slide I was talking to, the incidence of bicuspid aortic stenosis in India, 38% roughly, most of the cases. Elderly patients less. Next slide, please. Next one. Next slide, please. This is what I was talking to, bicuspid valve pathology, which is more calcified, raphe, more asymmetry, and heavily calcified, and dilatation of the aorta. This is the anatomical challenge. Next slide, please. Basically, this is most commonly used classification for bicuspid. Serious classification, type 0, type 1, which is the most common, and type 2. Type 0 only 2 fully developed cusps with one commissure, you can see that. So type 1 has again 3 types, where this mostly there are the 2 underdeveloped and 1 fully developed cusp. And this I do not want to go for details because this is anatomical classification. This is the most common type. And there is a sliver type 2 also. Next one. This is the challenge in the bicuspid aortic valve. Is it feasible to do BAV? What are the technical challenges? I'll be discussing about it. Who is valve to select? Role of cerebral protection, is there a role for it? When to consider coronary protection? These are the things I'm going to discuss, but these are the things which is most operator, when they do a bicuspid, they think about it. So this is the thing. the sizing of the valve in bicuspid valve is very important because if you oversize, the risk of annular rupture. Can you go to the next one? Next one, please. Yeah, if you oversize, there's a chance of annular rupture. If you undersize, there's a chance that valve might migrate, and there is high chance of paravalvular leak. Next one, please. The sizing is doing a sizing because asymmetrical structure, calcified, sizing the valve is very difficult. But basically, two ways it is done. One is a virtual basal ring measurement, which is done at the annular level, and other was the virtual Rafi ring measurement, which is done at the intercommissural level. This is done from the CT autogram. Three types of, once from the CT autogram picture, the three types of bicuspid aortic stenosis are there. Basically, one is a tubular. Sizing here is based on the annular diameter. Other is flare type, second one. Can you just go to the next slide, please? Next slide. Yeah, these are the three types. No, previous one. Just go. These are the three types of anatomy, bicuspid valve, aortic valve anatomy, and relationship with the devices. First one is tubular, where the size of the valve is according to the size of the annulus. Other one is flare type, where the size of the valve is according based on the annular size again. But taper type, where the size of the valve is based on the intercommissural distance. The first one. So prosthetic type selection is more important, balloon expandable or self-expandable. In balloon expandable stent, but balloon expandable valve, the external scars improve the sealing in complex anatomy, thereby chances of paravalvular leak is less because the high radial strength also is there. But the risk is, there is always risk of aortic injury, especially pre-existing aortopathy is there. Then in the bicuspid arm of the low-risk TAVI trial, 74% of the patients received the Sapien 3 valve, zero mortality and no disabling stroke were reported at 30 days, with low rate of procedure-related complication and excellent hemodynamic support. Next one, please. This is the prosthetic, self-expandable valve. These valves adapt better with irregular step finding zone of VA. But because supraannular valve design provides better hemodynamics, but the problem is here it's easy to recapture and deliver. Problem is again paravalvular leak is very high with this and chance of pacemaker implantation incidence is more. Next one, please. We have this new valve, Accurate Neo 2. This is better to seal reduce the paravalvular leak, and somewhat technically looks like it's better than the other two in treating the bicuspid aortic valve. Just can you go for the next? Yeah. Balloon aortic pre-dilatation, you have to do all these patients, you have to do balloon dilatation first. The pre-dilatation allows you to facilitate the valve crossing. And also there is a resistance, you can break it with balloon dilatation. Device size sometimes, very uncertain situation, you are not sure about the with this, but balloon sizing, you can have an idea about the exact size of the valve you are going to use. You can also, while doing the balloon, you can see whether the coronary artery is getting occluded or not, or there is a residual leakage. All these things you can predict. So all these patients undergoing TAVI, bicuspid valve patients, they should have first balloon dilatation. Can you go to the next slide, please? No, previous one. Yeah. Post-dilatation is limited to significant paravalvular leak or transvalvular gradient is very high, then only you should do it. Otherwise, you better don't avoid it. Next one, please. Procedural between transcatheter aortic valve replacement in the bicuspid trial. Initially, when the first, second generation valves are used, there's significant difference in terms of complications using these valves in bicuspid. But in new generation, the complications and outcome are almost same. So in the new generation valve of both self-expandable and balloon expandable, the complications outcome is almost same. So just wanted you to, next one please. Next one. Show you one case. This is a 74-year-old male, and he had bicuspid aortic valve, LF PCI, significant gradient, LB dysfunction, decided to go for TAVI, and we did this CT analysis. It's a type 1 bicuspid valve, and you see the coronary height was good, 20, 20 and 26, lot of calcium. So it's a bicuspid aortic valve type 0, bicameral aortic valve with Raphael flat type, severe aortic valve calcification. We decided to use a Evolute R 29 millimeter, pre-dilatation of 23 millimeter balloon. We had the access sealing with Proglide and Angiosil. This is the patient. He already had a pacemaker earlier. We crossed the valve, and then the aortic root angio, then we are crossing the valve. Then we dilated with a balloon, 20 millimeter balloon, dilated the valve first. And after that, we used a self-expandable Evolute R 23 millimeter Medtronic valve. And you see the result. No mild paravalvular leakage. Their coronary arteries
Dr. Podar.
Protected. And can you just go ahead, please. Oh, you are not doing it. Okay, go ahead. This is a calcium. And okay, go ahead. Okay, this is what it is. This is the patient had a pacemaker earlier. Next, we crossed the valve and dilated with 20 millimeter balloon. Next, then decided to use a 23 millimeter Evolute R valve, self-expandable. Next, you can see the result. Mild paravalvular leakage there, but coronary are protected. Gradient was very, very minimal. As it was an excellent result with a Evolute R self-expandable valve. This is another case, 51-year-old advocate, very, very critical aortic stenosis, and he was refused. He didn't go for surgery because ejection fraction was 22%. It was a high risk for surgery, and the surgeons told them, but he didn't want surgery. He told, for no, at high risk, I'll go for the next one. Yeah, this is the case. Second case, young patient, 51-year-old male, severe bicuspid aortic stenosis, coronaries were normal, but ejection fraction was 22%. That is why surgically it was considered high risk, and he was not willing for surgery because of the risk involved. She opted for TAVI procedure. With all precautions, we decided to take it. And this is the next one, please. Next one. Go to the next one. Next slide. Go to the next slide. Yeah. This is a heavily calcified bicuspid aortic valve. This is the outer CT analysis. And the coronaries, if you look at the coronaries were good size, height was good, almost 22 millimeter. So chances of coronary artery occlusion was less. Heavily calcified, no, next one, please. Next one, heavily calcified aortic valve. No, go back, go forward. Yeah, heavily calcified aortic valve, type 0 severe aortic stenosis. We plan to use a Sapien 326 millimeter self-expandable valve. Initially, we decided to dilate with 23 millimeter. This is we crossed the valve. Next one, please. Next one. Yeah, this is the autogram. Then we crossed the valve. Then initially we decided to dilate with a balloon, 23 millimeter balloon, and simultaneously we give injection to go next please. Yeah, we are dilating with a 23 millimeter balloon and simultaneously we injected the aorta to see whether the coronary artery is getting occluded or not. You can see the coronary artery is flowing during the inflation. We are giving the injection, coronary artery is flowing. That means chances of coronary artery occlusion is very less. Can you go ahead for the next one? No, go back. Go back, yeah. Go back. Okay, run it. Yeah. Run it. Okay, go forward. Next one. Okay. So we decided to use a 23 millimeter valve, balloon expandable, Edward Sapien 3 valve. Is getting expanded, you can see. And valve is deployed. Next. Next. Did you see something here? The coronary artery has occluded, left main coronary artery. Patient went in cardiac arrest. Cardiac massage is going on. And next. I managed to cannulate the coronary artery, left main coronary artery, and put a stent there. Next, patient was saved. Next, patient is in follow-up. So basically, these are sometimes it can be very challenging, life-threatening, and you should be really careful when you do it. These patients, because it's not many times because of the anatomic, the calcification, asymmetry of the valve, the chances of coronary artery occlusion is very high, so you should be very careful about it. So in conclusion, bicuspid valve patients are younger patients compared to tricuspid valve patients. TAVI in bicuspid valve poses technical challenges due to distorted valve morphology, asymmetry, and heavy calcification. Detailed CT analysis is very, very important in deciding about the size of the device. No randomized trials comparing different types of heart valve have definite recommendation, either balloon expandable or self-expandable. It is all depends on the case-based. And balloon aortic pre-dilatation is a must in all cases. You have to dilate it. Due to high incidence of coronary occlusion, coronary flow should be checked during balloon pre-dilatation, and selected cases require you should use coronary protection also. In selected cases, severe calcification, cerebral protection may be considered, especially because you are dealing with young patients with a lot of calcium. So if you can, you should do it, use cerebral protection. Paravalvular leak, annular dissection, rupture, stroke, a requirement for pacemaker was higher in TAVI with balloon aortic valve earlier generation. However, it is not so now. In earlier generation valves, it was little definitely high, but later on with the new generation valve, it is almost same. And but in key 30 days risk of stroke in valve in these patients. So you should be really careful when you do it. Select the size correctly and take all precautions if necessary. Protect the coronary, protect the cerebral protection also. Thank you very much for your attention.
Thank you, Dr. P. Sirath, for giving a very nice overview of bicuspid. I would like you to stay for 15, 20 minutes or 10 minutes, 15 minutes, because I have a very important talk, which is a recorded talk by Dr. Bernard Prendergast from United Kingdom, and he is one of the director of the London Valve. So he has recorded a special talk for 5-10 minutes In moderate aortic stenosis, I really want you to be part of this talk, and then we have a small live inbox by Dr. Praveen Chandra. Because he's recorded for this program, so we have to have actually this listening. Dr. Bernard Prendergast, you must be known, that during the last TAVI, he was given the Lifetime Achievement Award by Dr. Ashok Seth in India Valves meeting in Mumbai. So he's talking about TAVI in moderate aortic stenosis. Can we have Dr. P.C. please stay back, and we have a one live inbox by Dr. Praveen Chandra before we finalize the
the lecture recording. So just sketch sharing the screen here. Hopefully you can see the PowerPoint, and we'll just go to full screen. There we go. So, 3, 2, 1. So good morning everybody, and thank you for inviting me to contribute to this important Valve Day study meeting in Madrid. My name is Bernard Prendergast, and it's a great pleasure to join you here from London in the UK. A very poignant time, of course, for the UK population as we adjust to a new era and a new king. My topic today is to talk about moderate aortic stenosis, to talk to you about the clinical implications of this condition and ways in which we need to address our approach to its management and potentially to interventional treatment options. We all know that aortic stenosis is a common disease whose pathophysiology is very similar to that of coronary artery disease, and which, as a result of progressive thickening and calcification of the leaflets, is associated with progression over a number of years, the presence of calcification being an independent predictor of the need for intervention and ultimately a predictor of mortality. One of the difficulties that we face as clinicians is predicting the course of this disease for any individual patient, which shows dramatic variation from one individual to another. For many years, we've recognized that the baseline aortic valve velocity is predictive of outcome over time, and these nice data presented and collated by Raphael Rosenheck in Vienna many years ago provided the platform for international guidelines and current models of care. Perhaps for far too long, however, our approach to aortic stenosis has been dominated by this historical monograph and presentation with illustration by Eugene Braunwald many, many years ago in the late 1960s. Recall, this was an era before the widespread availability of high-quality echocardiography. It was an era when cardiology was still in its development as an interventional speciality, and it's an era where the only treatment for aortic stenosis was surgical aortic valve replacement, often at very high procedural risk. And the recognition that the onset of symptoms was associated with adverse prognosis was clearly adjudicated as the threshold for intervention, with a further recommendation that all other patients should be carefully observed, a so-called watchful waiting policy, until the onset of severe symptoms. And as we now come into the 21st century, with more modern approaches, greater levels of understanding, and new interventional tools available, it's time for us to rethink this paradigm and maybe reconsider what would be a more optimal approach. Because we now recognize that aortic stenosis is a disease not only of the valve, but also a disease of the ventricle. Our assessment of the valve can be determined by means of planimetry using echo or magnetic resonance, with adjunctive information from calcium scoring and PET. Perhaps more importantly, however, we need to focus on the downstream implications of aortic stenosis and its impact on the left ventricle in terms of initial adaptive hypertrophy and subsequent maladaptive diastolic and ultimately systolic dysfunction. And this inexorable progression is nicely described on this composite image taken from a paper by Mark Dweck and colleagues in Edinburgh, illustrating this unstoppable progression of disease, and now with incredible insights at ultrastructural level, which we've discerned by means of magnetic resonance imaging. And we recognize this ourselves in our patients, and particularly perhaps during the era of COVID, where we have seen patients who were initially asymptomatic deteriorate over relatively short time periods, often transitioning from a stable state to instability with fluid overload and heart failure within 6 to 12 months. And even in the best organized models of care, this presents a challenge to our treatment algorithm. We also recognize, as a result of increasing levels of research and advanced echocardiography, that there are other elements to the loading impact on left ventricular function. The combination of aortic stenosis with severe hypertension, for example, imposes a dual load on the left ventricle, and this is manifest with increased wall stress, indirect impacts on coronary perfusion, ultimately ischemia at microvascular level, and the onset of heart failure. Combined with infiltrative fibrosis, this also has an impact on diastolic and ultimately systolic function. And rather than thinking about mild, moderate, or severe aortic stenosis, we now need to think of a new paradigm of significant aortic of cardiac damage with downstream effects on the left ventricle, the mitral mortality related to the extent of the underlying cardiac damage. And these adaptive and ultimately maladaptive effects are summarized of transcatheter interventions. Coming at things from another way, we also recognize the impact of even moderate aortic stenosis in patients with heart failure. So in this matched study, you can see that the addition of moderate aortic stenosis to underlying left ventricular impairment was associated with adverse outcome over 5 to 6 year follow-up. From almost 250,000 patients with linked follow-up from national medical records over 1,000 days, was able to demonstrate the impact of aortic stenosis across the spectrum of severity, and underline in particular the poor outcome in patients with moderate aortic stenosis, which A, may be underestimated and in fact be significant or severe aortic stenosis in the context of left ventricular impairment, or may independently have an impact on overall prognosis. To positively influence left ventricular increased aortic annular air in comparison with cardiac surgery. And this concept with the hope that the results will be published and presented sometime within the next. We are now moving from an era of Whopper unload study, illustrated here on the left, which is approaching completion of randomization, with the hope that the results will be published and presented sometime within the next 24 to 36 months. And the progress study, which is at an earlier stage of development, but which will also incorporate the concept of cardiac damage, which I have outlined, which many of our colleagues may deem boring, into an era where relief of moderate aortic stenosis by means of TAVI may well be proved to be the answer that will benefit hundreds and thousands of patients worldwide. Thanks very much for listening.
It was Dr. Bernard Prendergast from United Kingdom. He had recorded the talk for ourselves. It's a recorded talk. It was very nice talking about. Now we have I may request everybody to stay back because the program will be like this. After this, we'll have a 15 minutes of coffee break, tea break, and then we come back because then we have valedictory function. A few guests of honors will come. Our chief guest is Bhagwan Krishna. So only guest of honors will be coming by 6:15 or 30. And after that, we'll have a small cultural evening by some singers. And I all want that we should try to finish by 8:30, and then we'll have a dinner. So everybody requested to stay back till dinner, and we should have a good evening. Good evening means it should have a good evening program. So may I request Dr. Siddharth, where is his live in box? Dr. Praveen Chandra is a dear friend, and he's from King George Medical College. He's a director of cardiac catheterization lab in Medanta Hospital. Earlier he was with Escorts Hospital. And we are also from the same King George Medical College. He is 2 years senior to me from this place. And this is a study, this was a live tower which was done by this. It's a live in box. So Dr. Siddharth is one of the associate of Dr. Praveen Chandra, working in Medanta Hospital. He has come all the way. Praveen is, actually Dr. Praveen is traveling at this time, end of the year. So he has requested Dr. Siddharth to talk about the live in box. So I will ask him to moderate. And how this is about 40 minutes. If we can reduce it to 10 minutes and tell about the basics of tower or TAVI techniques, technology, because we were talking about, he will talk about live in box session. He will show how the things are deployed in 10 minutes time. Thank you.
Good evening everyone, and good evening sir. Thank you sir. So I'll start the live this case. So this was a 74-year-old male who LV function was normal. He was a known case of CKD as well. And so he was type 0 bicuspid and with severe aortic stenosis, and he was planned for a tower. So this was a CT analysis which was showing the valve area, normal valve areas and everything, only small calcium. So, and also the coronary heights were reasonable in this case, and this aortic angulation was also 41 degree, which was also reasonable. So ultimately this was the femoral axis, femoral bifurcation was normal, femoral diameter was also adequate. So wall size for this area of 540 was 26 mm, so we started with Sapien 3 wall 26 mm. So now you can see a 6 French sheath in situ.
Dr. Nagendra will explain how we have done the puncture with ultrasound guidance.
So as we all know that creatinine is a major issue in these patients for long-term risk. So we want to prevent kidneys by not giving too much of dye. So ultrasound guided puncture is done, in which we have taken a sterile ultrasound probe, and on the base with probe we have just first located the bifurcation site, and then we go slightly almost 1.1 centimeter above the bifurcation, and then we turn the probe to perpendicular, and then we puncture in the anterior part of the femoral artery without any dye, because we are just going through ultrasound guidance. And this gives a very good access without any need for a dye and without any risk of future complications because of puncture done at a wrong place. So now we are going for a pro-glide insertion for pre-closure of the...
There is a 5 French sheath on the left femoral artery, and there is a 8 French sheath which is into the vein. Through this venous puncture, we are having the central venous access, and also we will put the pacing lead through this access. Now, before we go ahead, we will have to put pro-glides for pre-closure. So I am just putting a wire here, and I will just show you the steps of the pro-glide insertion. So here you can see that I am taking out the sheath, and Dr. Nagendra is putting this pro-glide here through this wire. And once the wire is visible here, we will push it inside, and he will take out the wire. We have not given any heparin or any contrast till now. You can see the spurt, and when the spurt is there, we can open the paddles, and I am pulling it up a little bit and plunging it so that the sutures are deployed now, and I will do a secured with the help of a artery forceps.
This is actually a very important technique of
pro-glide
putting a pro-glide. That means once you finish the procedure,
can be given now.
this will automatically close the femoral puncture site with the help of this. So these are the wires which are used, and because the puncture site is a bigger size, French size we are using as compared to angioplasty. That's why this is required.
So this is going to be a fully he is comfortable about. Okay. Now
Now a pigtail is put it into the aortic and
So we are in the, is very, very critical. Now can you show down? Can you show down? Show down, show down. Okay, some more.
From left side pigtail is inserted and now TPI is being inserted into the right ventricle for rapid pacing during the wall deployment.
Yeah. So we can check whether the
patient
times these, so the perfect. So check at higher rates, and because sometimes at higher rates it can miss. So I'm going
Temporary
to
pacemaker lead is always
check
there.
it at 120. Still it is 1:1, so we are fine. We are okay. Into not going out. Ho रहा चल रहा है. देखो dry gauze.
Valve crossing.
Normal.
ऊपर. Dilate the universal dilator, and as you can see here, it goes quite easily, no problems so far. Okay, fine. So this is done. Dilatation of this artery on the right side is done. Now we are going to put the E sheath.
So this E sheath has a special quality.
Which will expand it, and I will take out the wire to flush. Can somebody hold the wire?
Yeah. The blue sheath.
The stage that we have the AL1 catheter into the aortic root, and we are ready to cross the valve.
Balloon.
The first step is to cross the valve with the help of a catheter. To put the wire, do balloon valvoplasty, and then put the valve.
Okay, so we have the straight side.
Tip is inside. Tip is
but,
inside.
Tip
This is
inside,
actually
but it is not
a
going
very tricky
because of
procedure of putting a wire
architectural
crossing the aortic
problem of
valve.
the
It's not that simple because the orifice is very narrow. It's done it very
Now
well.
it is okay.
Now you can see that wire is, and the AL1
we are
catheter
inside
is already inside the left ventricle
and
from
it
the
is giving
aorta.
rise to some ventricular ectopic beats, and now it will settle. This is a exchange length wire, which is a Teflon wire, normal strength, and I'm going to now position it well deep inside the ventricle. I don't think so. We'll need to check the pressures because it is already confirmed, and although we do,
tight stenosis, so
it's a very tight stenosis, and
so now Safari wire is in left ventricle.
Hello, 11 crenulate.
And
LO 11 in
valve will be passed across this wire and
magnify a
deployed.
little bit. We are
So
doing a
now
pacing. So pacing on.
We are trying to
Pacing
balloon
on.
with rapid pacing.
This is again a very important
170.
technique. That means while you are doing a pacing
the BP
at the rate of
dropped now.
250,
Okay, go up.
180, 180 to
Deflate.
200,
The balloon is slipping.
at
Pacing
that
off.
time we are actually doing the balloon inflation.
Pacing off.
Why this is required? Because
So the
otherwise,
balloon is moving a
because of the
little bit,
action
so
of
we'll
the
go a
flow,
little
the
higher.
balloon
Pacing
actually is
rate
not actually
is about
static at that
180.
place.
Deflate. Pace. So we have
So he
done
has already
the
performed the balloon
pre-dilatation.
aortic valvoplasty, but that means pre-dilatation,
Not coming?
so
Fine.
that to make a space for the valve to come.
And center. Wire.
Now the valve is coming. This is which one?
For portal, please. May increase cranial. 80% of the movement inject.
So this is
some
how the
contrast.
balloon is
Up till
now,
no
this
contrast
stent,
has been given.
sorry, this valve is
So we
being
will
placed,
position it a
positioned
little bit
across the aortic valve.
deeper, right?
This is actually from, I've just confirmed, this is a my
He will
valve from
guide
Merrill
us
company,
for
and now he's
everything.
already deployed this valve. So this part is very important, very crucial, because the placement,
Same process.
positioning, you have to
Just
just
hold on.
avoid the coronary
We are
arteries,
checking, Dr.
and then do
Nagendra
balloon
is
inflation.
suggesting
It's a
that
balloon
we
expandable valve.
Check it first and then do. We can go a little bit deeper, right? We can go a little bit deeper.
A balloon expandable valve. Now this will deploy the valve
Okay.
right at the position where we want. So valve is already
The
deployed.
pressure को निकाल दें क्या?
If you have to dilate again, then we can keep it all.
We'll check the gradients now. We need a pressure line.
So,
Male to male.
So overall, up till
Hey,
now,
we have to give it.
everything is
उसको जी,
okay.
उसको छोड़ दो, ये लगाओ.
so they perform, they are
वही
performing the
कहने का
echocardiography just immediately
So
after
now
this
once
procedure
we are
inside the
done,
cath lab.
Okay, I'm taking this out, and it looks good. It looks good. Bring them together.
So this was the
And this
first
is
initially,
the
if you remember, I told you that they have to proglide, which was
second
kept.
suture.
Now they have removed everything, and
So
now
there
with
is
the help
some
of this, they will do the
oozing, so I will-
suturing. There is no
You can leave
compression
it
which
now.
is possible.
Leave it now.
They do the suturing
There is
and the
no
arterial
ooze
hole,
at all
which
now.
was created because of the
It's
14
okay. You can see now everything is
16
okay.
French sheath.
Absolutely
When we do
fine.
angioplasty, we use a very
You can
thin
leave it now. Leave it
catheter,
now.
which is 6
No
French
leakage at all.
or 7
And
French
I think we
maximum.
are almost
Normally
ready
6
to
French. But
take
here
out
he was
the
using
wires,
16
okay?
French sheath.
This is the
And that's why
wires out.
the opening, the hole inside the
Okay.
femoral artery
Compress it
is
little,
quite big.
compress it.
It will not compress. You have to do either surgical cut
So
down to close it.
sometimes there is a
But this is a
mild ooze, we
technique
can
which is
do a
percutaneous
compression.
closure of the femoral
And,
puncture.
I will do
Percutaneous
the whole
closure of
step
the
once
femoral
again.
site. With
And
the help of it,
we will
Proglide
check
is
it
the
with
name of the device
Doppler
which is introduced by this.
Bleeding, just a little superficial oozing, that's it.
Because these wires, actually these are the
Okay.
sutures which are already inside the femoral artery, and then you have to just tie it off.
How much is the prota given?
To summarize.
So this
How
was
much?
a type 0 bicuspid
This is how much?
valve and 26 my valve
This
was
was 1 hour
deployed
before.
across
One
the,
before
there
now.
was no residual, no
So we
AR
are done,
and no residual
and we will pull
gradient.
out the
Half
sheets.
Patient went home
The
after
patient
a
is
day.
Half reversal.
feeling good. You can just compress it a little.
So is what Siddharth was saying, that patient
So-
was discharged in 2 days' time,
कैसे हैं आप
and the
ठीक हैं?
good work was
You're
done
good?
in a
Okay?
percutaneous by the
Fine.
percutaneous
The
technique.
patient is feeling absolutely fine. Yes.
So this
Yes,
was
we-
actually a
yes,
case
we-
demonstration by Dr. Praveen Chandra, and it was already about 6:23 p.m. So I will request everybody, but everybody has to come back. It's very important because some few guest of honors will come, and we will have this. And this is almost end of the scientific program. Siddharth, you have to stay back till dinner. But we can go quickly for the coffee and come back within 10 minutes. To be in the meantime, they will do the setup for some songs program. Dr. Podar will be singing. Dr. Podar, you could not chair a session, but we have the memento for you. So do we have a memento for Dr. Praveen Chandra? It's already made, or we can have something? Hello. Dr. Israni is one of the important. Okay, so Dr. Israni is actually a joint secretary of National IMA, which is very important. Huh? 9, okay. So National Body of Indian Medical Association is important. So he is a joint secretary there, a good friend of ours. And we can have now felicitation of Dr. Siddharth. Dr. Podar. Podar ke liye. Maybe you hand it over to Dr. Praveen Chandra. Dr. Podar, can you come on the stage for receiving this? But you have to sing a song actually. You good? I heard you singing. You'll sing one song, and that is why this is done for you. After you. But I request everybody, because we are going to have a one hour, half an hour valedictory function, and then after that we will have this cultural evening.